Sa, 1, 2, 3, prova. Prova 1, prova 2, prova 3. Sa. T'arriva? 1, 2, 3, 4. Prova 1, prova 2, prova 3. Sassari, Sassuolo, una salamandra del Salento. Fi. Fi.
E adesso arriva, sì, adesso mi arriva, ok, sì, prove tecniche, 1, 2, 3, 4, 5, 7, 8, 9, prova, e, e, ok, va bene. Mettiamo qui. Leva sta cuffia che io voglio sentire.
Prova. Prova, prova. Ok.
Mi senti? Mi senti? 1, 2, 3, prova, sa, anduia, soppressata, anduia, soppressata. Va bene. Sa. Sa, mazza, perfetto. Porca miseria. Sa. prova. 1, 2, 3, prova. Prova. Sa, sa. Ok. Inquadra.
Allora, buongiorno a tutti, se vi accomodate.
Good morning, everybody. We are about ready to start this session. We're going to talk about retreatments in radiosurgery, stereotactic radiosurgery. I'd like to thank Dr. Gentile for organizing this interesting and very interesting event. I would like to leave the floor to Professor Gualdi, who will talk about recurrence versus fibrosis in radio treatment patients. Is biopsy always necessary? Thank you, Professor Gentile, for inviting me and for the fact that I'm the only diagnostic radiologist invited to this prestigious event. I would like to start straight away with a basic definition. Of course, early identification of a recurrence does improve the outcome if the therapeutic choices are surgery, RT, and CIT. But also a recurrence after RT is particularly difficult for changes induced by RT on healthy tissues, surrounding healthy tissues. And this is very important because right now we have safety therapies available. This is some of the results in the head and neck, lung, and abdominal setting, the prostate. We will start with the prostate biopsy with the suspect of a recurrence. This is with echo guidance. It has a percentage of success which is rather important and significantly varies between 5 and 93%. Of course, the biopsy not always is able to diagnose the recurrence, and in the worst cases, this will not manifest itself clinically, and also it could be a latent carcinoma. And this is always a problem in the sense that it represents a challenge also for the pathologist. We know that between 15 and 25% develop a local recurrence. And this recurrence can be, as I said, local, only with metastases, but both local and with metastases. And it's important to establish if the patient is a candidate to safety therapy, surgical or systemic therapy. Fibrosis causes the need for RT, but this makes it difficult to diagnose the recurrence. If T2 are not detectable for a diffused hyposignal, and then if there is a limited power in terms of what would happen in a basic condition if the patient has not received previous RT. This is in a spectroscopy setting. The citrate go down more quickly in comparison to the choline, and this cannot be used to detect the tumor, and this happens in roughly 70% of the cases. The residual tumor can be identified only by detecting high levels of choline, as you can see in this patient. This is the picture 6 months after the radiotherapy, PSA 0.1 after 6 months, and PSA is 2 after 1.5 years after radiotherapy. This is another patient, PSA 10, high choline, citrate. This is the early diagnosis, and then after 2 years following the RT, choline has raised. But like I said, the spectroscopy not always gives a positive result, because radiotherapy does, or can induce the raise of the choline. So we give an important value to the sequences obtained after perfusion with the gadolinium. This is just an example of a patient. This is the initial biopsy. The The diffusion shows this high level of cellularity in this area. There's an intense time signal with a peak over here, which is a typical feature of angiogenesis. This is the control after 1 year after radiotherapy with the PSA, which is now normal again. And this cannot be appreciated anymore in terms of alteration of cellular component. But the peak has indeed changed, and there's a slow, gradual increase with no peak with the plateau. Of course, both the diffusion and the imaging obtained after administering gadolinium are more valid than spectroscopy. Of course, if we take a look at and we use all the techniques, we use the maximum amount of data and we can obtain the maximum amount of information. Choline is high here, and we have the peak in the chart, which is typical of recurrence after RT. MRI is positive and useful. The PET gives us extra information, the value in literature in terms of total accuracy between 40 and 85%. Certainly it has a high specificity and a high VPP, positive predictive value, decreased sensibility, and VPN, and also PSA trigger values have increased. This patient was on a positive MRI, and PET is also obviously positive after RT. But the most important advantage is the fact that they can help to detect the site of the disease and help us with the choice of the diagnosis and the therapeutic options. This is lymph nodes. This has a metastases, and this has multiple metastases, skeletal metastases. This another patient, a recurrence after RT, and widespread bone metastases. So these metastases can take place, and this is useful. The PET turns out to be useful in cases such as this, in the peri-ilar region, and this biopsy, in this case, plays an important role for histology confirmation. What do we expect? We expect more from the PET-MR because this has been demonstrated to give a significant contribution not only for the metastases but also on the prostate gland, demonstrating the recurrence of tumors in the seat. Then, of course, the PET with the gallium is also with lower levels of PSA, lower than 0.5, is able to detect the recurrence of the disease. So the positive impact in managing patients with low PSA is a local recurrence that can be treated with RT, which is a potentially curative. In oligometastases, there are detective treatments, stereotactic radiotherapy on the prostate. This is a recurrence of just 8 millimeters after RT and radical prostatectomy. This is a lymph node of 4 millimeters. Let's move on to the lung. This is an extremely complex problem. SABR today is a valid alternative, as we all know, to surgery, and it has local control rates at short and medium term and survival terms, which can overlap and be very similar to the surgery after 5 years. A recurrence in the radiated side are pretty rare, but can be potentially treatable. But for a effective follow-up, we need to know the type of RT, the dose which is administered, because there's a linear proportion between the actinic modifications and the dose, but most of all, the knowledge of the times of start and end of the RT. Just to give you an example, this is the treatment plan, 0 months, and after 3 months, you can see that after 3 months, there's after 6 and 18 months, there's been a significant reduction of the size and a change also in the morphology and density. These are normal findings that the RT, the radiotherapist must know, of course. This is the plan of treatment with 3D CRT, a 70-year-old patient with adenocarcinoma. This is the ovary consolidation within 2 centimeters from the margins of the tumor. And this is the picture after 18 months. What does this tell us? The radiologist has signs of high risk of recurrence at the CT scan. And opacity, which is increasing, progressively increasing, after 12 months. Bear in mind that to increase have a very high sensitivity, rounded margins, disappearance of linear margins, the loss of aerial bronchogram, and a craniocaudal growth higher than 4 millimeters and 20%. We have the sensibility and specificity. Take a look at 12 months has a sensibility and specificity which are considerably increased. Another example, this is a patient with no recurrence before therapy, after 3 months, and after 6 months. Take a look at the 6 months. The opacity is obviously increasing, and this does represent a risk factor. What do we do? A PET, a CT scan, a biopsy. The patient didn't do anything. After 12 months and 24, the disappearance. So this patient did no local recurrence. On the contrary, this patient had a recurrence 6, 12, 21, and 21.5 months. These are the risk factors: increasing opacity. Again, the increase after 12 months and the disappearance of the linear margins that become rounded, and the other risk factor is the loss of aerial bronchogram. So more than 3 risk factors have a sensibility and a specificity which is extremely high. This is a very interesting study because it used the biopsy as a systemic approach for recurrence. So that is extremely interesting. Take a look as more than 3 months high specificity and sensitivity. The PET is very debatable and has been debated because they follow the same onset with the fibrosis that evolves within 2 years, which is the time that the majority of the local recurrences onset. So the recurrence it manages to detect the recurrence better than the CT alone, and others think that it can, by mistake, select patients with a high risk, and the biopsy is not necessary. And we've seen this, that the CT not always allows to differentiate between the residual or recurrence of the disease with a radio-induced pulmonary damage, most of all in the period after the radiation therapy, before the anomalies have stabilized. This SUV, more than 5.6, which points to a residual of disease and a limited possibilities for CT scan and MRI. These are the post-actinic modifications. This is the patient treated with a maximum SUV of SUV of 6, maximum SUV 3.7. Here are the onset of post-actinic results. And this is quite different from this other case. This is the initial framework. the SUV going from 4.9 to 2, another control after 5 months, SUV goes up again, and after 5 months, SUV has considerably increased, and this is the onset of the new onset of the disease. We've seen that we can have a temporary increase of SUV, but never beyond 5 in the first 6 months after the SABR, which is coherent with the normal inflammatory response of the irradiated parenchyma. And a threshold of SUV of 5 can serve as a cutoff to identify lesions with a high risk of recurrence. And the PET CT scan should never be performed before 3 to 6 months after the RT. And we have seen some false positives with a SUV maximum of 7. This is an interesting flow chart. I'd like to share this with you because it shows the risk factors. If the risk factors are more than 2, based on the CT scan, this is an indication to the PET that can give SUV of maximum 5, yes or no, and this tells us if we have a low suspicion, and then a follow-up with a CT and PET and CT. And if there's a high suspicion, is the patient can be operated, yes or no? And then if the biopsy has or doesn't have a relevant role. This is the head and neck. What can happen? What do the images tell us? After surgery or after radiation therapy, the assessment is difficult due to the altered anatomy and the presence of artifacts. This is a patient who underwent preservation of his thyroid, and it's difficult to assess all these captations if in the region of the head and neck. This tissue near the posterolateral tissue on the right. Take a look at the malleoidal left muscles, or behind the iotic bone on the right lateral side. It's difficult to understand if the PIT is performed shortly after the radiation, what is due to recurrence and what is due to fibrosis. It is certain that the patients with good response to RT have a reduction of the uptake of the FDG compared to the initial tumor, while the persistence of a high uptake indicates a bad response that must induce to modifying the treatment. This is a CASG with an adenopathy level 2, SUV max 4.5. These are imaging of the MRI, and then the follow-up at 18 months, which shows the total disappearance of the tumor and of the adenopathies. The PET-CT has demonstrated more accuracy compared to MRI and CT scan. Sensibility and specificity of the PET go between 94 and 82%, and it is higher when the exam or the test is performed at least 10 weeks after the treatment. The sensibility is more when the local assessment is 94%. This is another example. This is again a CASG, which has disappeared after radiotherapy. This is an MRI, but after 3 years, the recurrence in the EMI tongue, and this is the recurrence, and is no longer there. The inflammatory modifications after the chemo and radiotherapy give false positive if done too early. The post-radiotherapy phlogosis in the first 2 months after the treatment can also take 24 months. Many studies tell us that the test should be performed at least 2 or 3 months before radiotherapy, and a negative PET can rule out the recurrence of the disease in patients who have received chemo combined with radiotherapy. This is the MRI data and a detection of the head and neck squamous cell carcinoma, and good results within 10 weeks following radiotherapy. This is another case, follow-up with a carcinoma of the base of the tongue, 6 weeks after CHT-RT. The PET shows a captation, no diffusion, just an ulcer, and the biopsy confirms the absence of recurrence, just some necrosis and phlogosis. The accuracy for recurrence of the PET MRI is 91.5 and is slightly higher than the PET CT scan. But however, the differences are not statistically significant. The data show that the imaging method is a combination of PET, and this can give additional elements. The accuracy of the recurrence, again, this is another patient, a 31-year-old with a SCC of post-surgery, and the RT is completely negative, but after 3 months it shows a recurrence, and this is confirmed by the MRI. So the PET is the test that gives us more information. The final point, very quickly, the encephalon, we have 4 possibilities: the recurrence, the pseudo-progression, radionecrosis, or pseudo-response. And the radiologist is forced to know and understand exactly the cases to assess appropriately the case. We know the neuroblastoma have a high level of recurrence, and the pseudo-progression after 2 or 3 months from the end of the CIT plus RT, we can see in the onset of increased area post-contrast dye that can solve over time and do not represent a progression. Radionecrosis involves a dose-dependent damage. And the pseudo-response is the disappearance of the increase of the pathology tissue after the treatment. This is the recurrence, and it is evident how the blood volume is positive, the diffusion is positive, and there's the areas with higher cellularity have a low ADC, and this alteration is evident between the colon and ADC, which are higher compared to radionecrosis. This is a pseudo-progression. This is associated to the use of TMZ that damage the BEE, helping the passage and increasing the efficacy. And these can be differentiated. The blood volume is negative, and SMR is also negative. Radionecrosis is extremely difficult because both the onset and the progression of the disease. This is a patient of 57 years old, motor aphasia, previous intervention of removal of a GMB, and gliadel in the left frontal seat. This is after 6 months, and after 8 months, spectroscopy and blood volume are completely and totally negative. Pseudo-response with the anti-angiogenetic drugs cause a sudden reduction of the increase after contrast dye to reduce the capillary permeability and can simulate a reduction of the disease. But here the MRI is extremely interesting because it shows the increase of the disease and the increase of the volume. The PET has a very bad sensibility and specificity for the high uptake of the surrounding healthy tissues. Traces can be amino acids with high uptake, which all give us major information. This is the difference between a radionecrosis and a macrosis. Once again, the chart shows the captation and time ratio with a gradual increase with radionecrosis, and on the contrary, in the metastases, there's a quick captation and then the plateau. Unfortunately, I had very little time for this, but the conclusions are that in the encephalon, the use of all the MRI techniques improve accuracy. In some cases, it's only by evolution, analyzing the revolution of MRI, and we expect more from the new traces. Head and neck, we have seen that PET and the CT scan has demonstrated high levels of reliance compared to MRI for diagnostic accuracy. In the lung, we have seen that the majority of the recurrence takes place in the first 2 years, but the semiotic of CT scan and PET have allowed us to develop guidelines for the follow-up, including biopsy. In the prostate, the case with which we started, the PET and CT scan allows to guide the treatment of a recurrence after RT, distinguishing if it's just a recurrence, oligometastases, or multiple metastases. And we expect to see new outcomes with the gallium, with the PET MRI, which can allow us to carry out a safety MRI in a better time window. Thank you very much.
Grazie al professor Gualdi per
Thank you, Dr. Professor Gualdi, for your presentation. The most important message is in the last slide. You can see the consistency of the behavior.
Questa fase, diciamo, generalizzare.
So we can generalize, and practically is impossible. So our question is biopsy always necessary? The answer probably is yes, because sensitivity and specificity levels at 100% have never been seen. And of course, there are considerations of clinical considerations. We see in the prostate. Today we do salvage of the nodule and we never perform a biopsy. And other situations, similar situations with radical prostatectomy, and also because of the morbidity of the treatment, it's always associated with the necessary biopsy. The speaker is off the microphone. Okay. It depends on the time frame, because we have these changes providing false positives. So we need to use all techniques that we have available, and very often we're not successful, so a biopsy is necessary. If we're able to combine data from the MRI and data from the PET, or hybrid machines, like a PET plus an MRI, we can be at our best. And it is essential for us in view of a retreatment. So we not only want to know if there is a recurrence, but we also want to know where the recurrence is, because
col trattamento. E quindi diciamo è fondamentale anche in quest'ottica, cioè di valutazione dell'estensione. Non so se ci sono domande, almeno una domanda la possiamo catturare.
Io volevo fare un ringraziamento a Gianfranco per la sua presentazione molto didattica, che poi è quello che noi facciamo tutti i giorni, che dobbiamo, prima di rimandarti il paziente con un dubbio, interpretarlo noi. che già la prima cosa il paziente arriva, ci guarda mentre noi guardiamo le immagini e dalla nostra espressione legge più o meno quello che è il nostro dubbio. La domanda è molto mirata, si parla molto di accumulo di gadolinio se ripeti molte volte le risonanze, e tu hai detto che noi dobbiamo osservare per un po' di tempo questi pazienti. Cosa ne pensi?
The gadolinium for renal failure, is that what you're referring to? Well, these are findings which I showed with the pseudo-progression. We need to pay great attention to the medications that we use, because some can cause alterations and can simulate a new onset of the disease which could not be there. These drugs, such as anti-VUFG, which you've seen, these all give an alterations of the endothelium. So we do the MRI, and then we see that there's an increase of those levels, and we think and we assume that these is a local recurrence. Instead, these are just normal changes for pharmacokinetics. So this is something else that we need to be particularly careful about. We need to make a cultural effort, a joint, careful effort to interpret the images as best as we can.
Thank you. Also, because very often, and we heard this yesterday, often there is a population of patients, lung patients, that do treatments without a biopsy, because it's difficult on the patient because of the many concomitant diseases, other diseases. So, and this complicates the situation. So
I did show you some radiological signs which are extremely important, and the radiotherapists and the radiologists must understand that it's fundamental to look out for these signs and to know what the PET, the distance from the lung, to avoid false positives. And the radiotherapist sees this report, now what do I need to do? So it's I know that it involves a cultural effort, which I was referring to before.
And yes, we need to involve all professionals. Okay, well, thank you. At this point, give the floor to Dr. Valvo, and she will discuss the radiotherapy in retreatments.
Grazie mille. Scusate, la tecnologia mi tradisce. Grazie mille dell'invito, prima di tutto.
Thank you for your invitation, first of all. Thank you, everyone. And thank you, Dr. Sanguinetti. I'm kind of a little scared about him because he's a bad person. Well, thank you again. Because here I have a chance to discuss about something new that we have in Italy, a Center for Radiotherapy. And I can show you, I have a chance to show you what are the benefits of this treatment with particles. It's also a very challenging field, the field of irradiations. That's Dr. Sanguinetti's fault. It's always him. Some technological problems. Okay, particles, thanks to their selectivity, and they produce damage to the DNA, and they have not effect on the cell cycles, and they're also active. They're a perfect candidate and very useful weapon for radiations. Thanks to selectivity, we cannot irradiate tissues that are already irradiated. There is a lower toxicity, and we can have a dose escalation while we attempt to recuperate these patients and treat these patients after radical treatments. The use of carbon, which is very effective from a biological point of view, and 3 times as more effective than protons, and they can be resistant. And this is we're in sector we're talking about the resistance because these treatments, these tumors, relapse after radical treatments. In the literature, there are studies, and this is a recent study, which have shown that in a limited number of patients after treatment with photons with the radical doses, a dosimetry study comparing the best radiotherapy treatments with photons versus radiotherapy with protons or radiotherapy with ions, carbons. You can see the pictures as different. And researchers, so this was a multicentric study, and researchers say that the advantage compared to conventional treatments, the benefit of protons on organ risk is 40%, and it will be at 54% if we're talking of carbon. Who uses these particles? So the benefit between protons and carbon in the dose reduction, it can be seen in this slide. So we have a prescribed doses falling to 22%, and it's more rapid with carbonium. So these are some German preliminary experiences from Heidelberg. 28 patients were treated with different diseases, which had already been irradiated, and they administer another dose of 21 gray with carbon, and there was a local control of 92% for chordomas and chondrosarcomas. For other tumors, there are no data, but this study has shown that there is no severe toxicity above grade 2. And this is another study, always from Germany. 25 patients with chordomas and chondrosarcomas already treated with the German way, with the boost of photons and carbon, which were re-irradiated with 51 gray of carbon. There is consistency with the range that goes from 46 to 60. And there is a local control of the disease, which was high. Furthermore, interestingly, even though a higher dose can be good for local control on smaller lesions, however, this is not statistically significant. Maybe authors want to say that this is less important. So, this study is interesting because they have re-evaluated the toxicity present before the retreatment. They evaluated the toxicity of all cranial nerves before retreatment, and this refers to the previous treatment, and they've seen what the improvement is, what cranial nerves were improving after retreatment and what were worsening. And they saw that some were improving and the one that were deteriorating had a new toxicity, like 5 necrosis in the lobotemporal and 3 cases of purulent otitis. And this is a very important study because shows us that there are some unexpected toxicity. Other 16 patients that were retreated with chordomas of the cranial base with higher doses. There was a median dose of 75 gray with protons. So we were trying to cure these patients, and the result, it's 19% of G3 and G4 toxicity, which is severe. This group considered dosimetry before the treatment, so organs in the first treatment, and the dose received during the second treatment. And they have discovered that there was a G4 toxicity in 2 cases, which was unexpected. There was an ischemic necrosis in an area that had received no dose during the second treatment. So even though it was a safe area, there was a necrosis and a fistula as well. And they saw this because they assessed the dose that was received to the vertebrae. And they were responsible for the trunk necrosis. The same for another area of the brain. We saw the difficulties of a second treatment. This is another experience from Germany. 16 cases treated. There's still head and neck and spine cases. 16 patients treated, no toxicity, no G3 toxicity, and the conclusion is that this treatment is safe. Same center, 52 consecutive patients treated with raster-scan carbon, ion therapy, 51 gray, the dose. These patients had no other options. Of no type. Local control at 1 year is 70% and 47% at 2 years. So half as much. Half as less, and this can be, of course, a good result. But we see G3, G4 toxicity, especially G4, with a 38% of carotid rupture. So this is one of the many complications of this kind of treatment. But in the second treatment, we should consider this. We'll see when we need to consider this. Again, this is a study from Germany. So recurrent rectal cancer, 19 cases with a wide range of dose, and the local control at 1% is 80% with no G3 toxicity. Germans are very careful, so we can trust them. This is from Japan. They have a long history with carbon ion therapy, and we're talking of a local recurrence of rectal cancer never treated. They treated many cases with a dose escalation, and they saw this kind of local control, high local control with high doses, 73 grays of carbon ion, and a survival of 51% at 5 years. So colorectal cancer patients with no toxicity. These are data from the knees compared with the best data. We're talking of aggressive surgery with local recurrences. These are examples, again, from Japan, that I borrowed from our Japanese colleagues, which are impressive. So, if we take their experience and we consider retreatments, they have published 46 cases of re-irradiation of local recurrence treated previously with different types of treatments. They were able to treat them with the 70 grays of carbon ion, 16 fractions according to the Japanese model. These are very impressive images and this is 30 months after treatment. And these are data regarding local control for re-irradiation for 47 patients, which are even better after the first treatment, maybe because they can re-irradiate smaller lesions. So that was easy. And these are data concerning the overall survival for re-irradiation. So we have 29.5% 5 years, and this is better. And then we compare data with the best surgery, and data, this kind of numbers are twice as much. With toxicity, which is moderate, 2 cases of G3 neuropathy, and 5 cases of gastrointestinal toxicity due to spacer insertion. They use Gore-Tex spacers, and so they think that this may cause complications. So this is the CNAO experience, and there are few data available for this. So this is the CNAO experience. We have quite a good experience with retreatments. We have re-irradiated 156 patients. These are the inclusion criteria. A single site for the disease. These patients had no other therapeutical options. So that was Pavia, our hospital, was their last option. So we had a plan of care. These are the histological results. You can see the most frequent tumors are radioresistant. We only have 35 ACC, so head and neck tumors, basically. The rest are salivary glands and sarcomas and rectal tumors. The majority of patients were treated with only 1 session of radiotherapy. 4 patients were treated more than once. The re-irradiation time was 6 years, with a maximum of 6 months and 49 years. The mean time was, on average, 3 years. 86 patients were treated with carbon ion, 70 with protons, 54 was the total dose, and 48 the total dose with protons. So we were trying to provide radical doses, and the same thing with protons. So 48 gray. Talking about radiation, we choose carbon with resistant histology and the need of a more a steep gradient. And we use protons with more superficial lesions, which are near to mucosal areas, and especially in squamous tumors. And this is our case mix. So 48 patients, 35 patients had glandular, this kind of tumors, ACC tumors, with different fractionings. It depends on where the lesion was located. And these are our results in terms of overall survival and local control at 1 year. Again, bear in mind we're talking about patients with no other therapeutic options. But if we look at this, we divided patients based on the volume of GTV volume, with a mean volume of 39 cc. So, of course, smaller tumors were able to get higher doses. So if we look at our cases, we see that the local control is more elevated with smaller tumors. Of course, that's easy. And bigger cancers, the local control is less good. Of course, this is valid for carbon ions, but also in general when we talk about radiotherapy. We were good with this. This is a patient with a diagnosis of ACC nasal cavity rhinopharynx, treated with 68 gray of carbon. This is the PET before and after treatment. In 2013, you can see there is a disappearance of the lesion. You can see the importance of the PET. We use the PET and we borrowed this from our Japanese colleagues, especially in salivary gland tumors, with less inflammation. And so we're also conducting a study on the predictive aspects of the response. We do this at 1 month after the treatment. These are the results of the MRI, and that's our patient. So positive results. So the retreatment can be used also with this. So 35 patients with the squamous cellular carcinoma, and this is the local control, less satisfying. At 1 year, it was 20% with an overall survival of 35%. And then we divide the patients based on GTV volume. So smaller tumors, higher doses, and of course, higher volumes, lower doses. So smaller tumors, 48% local control. Bigger volumes, we don't reach 1 year. So probably with the bigger tumors, we do not have to, we shouldn't irradiate maybe, but it's helpful. It's very helpful to demonstrate this. This is our experience with chordomas, and this is just to show you that there is a consistency and what we should look at when we develop a new plane. 54 the mean dose, and 56 with carbon ion. And this is local control with chordomas, a chondrosarcoma, 71% the overall survival and 60% of local control. If we group toxicity for head and neck, 116 patients with head and neck tumors, we see that at the end of the treatment, we had a 5% of mucositis, G3, and brain radionecrosis at 3 months, and ulcers also after the treatments, lingual ulcers and neuropathies. Of course, the follow-up is it's not too long, so we're satisfied and we'll wait. And it's in line with the literature. So 9 patients with local recurrence of rectal cancers, already irradiated, 51 gray, the prescription with carbon ions. This is an example. 2 examples. We use PET, CT, PET and MRI to identify the target volume. And these are our results. Local control of 90%. This is only a short follow-up, but no toxicity, no significant toxicity or severe toxicity, and a survival of 70%. This is the end. If we consider the entire pelvic area, all patients demonstrate that there is recurrence of neuropathy. So patients treated with high doses can develop neuropathy, which can be invalidating. I'll show you some of our challenges. When a patient is referred to us, so why are we agitated? Because if we did not have the DICOM plan of this patient, looking at DDVH, we would have thought that the optical nerves would have had a D1 of 42 gray, so still emerging. But we have the DICOM plan. We were able to contouring the organs that we wanted to, and the nerves received 52 grays. So at least we know what we're talking about. But it is necessary that doctors retreating the patient know what happened before. So, and patients that are referred to us, of course, we need to ask for their previous therapeutical plan. And this is for the good of the patients. And now there are also critical organs, for instance, the carotid artery. And this is an example of what we have done. This patient had a previous treatment. This is our plan, 67 gray at GTV. But this patient had this kind of history. ACC previously treated with the many other options, with radiotherapy treatments, no other option, PET and MRI, a very important recovery. We have a plan of care with 54 grays with carbon ion. This is our result before and also after 1 month after treatment. The uptake was lower, and we have done a sparing of the carotid artery, and we were able to save the brain trunk, which had received a very high dose of treatment. So no problems on that area. So, and the patient had a progression at that exact site, and the rest of the disease was controlled. I think we did good, but maybe we could have done more, talking about the carotid artery, because going above 120 grays within the bone tissues is safe. And maybe this choice is difficult, but in this case, it's very challenging. And then nerve sparing. Organs that were not at risk before are now at risk, and so we're able to contour all nerve roots. And it is important that in the rectal relapses now, this is an organ at risk that we need to respect. And this is something that we do with rectal cancer. We operate patients and we try to separate this organ at risk, which is near the relapse, and we're able to irradiate the recurrence properly. We also use the surgical organ displacement and spacer insertion, which was inserted between the rectum and the lesion, so we can create a gap that allows us to treat the tumor at full doses. We also do this at the beginning. This is a rectal cancer. A spacer was inserted to detach the bladder. They're made with silicone. In conclusion, we can say that hydrotherapy can be a very good option for re-irradiations. So this is something that we can do because it's useful. We start having preliminary experiences. We think that organs at risk can be spared. Toxicity have acceptable levels, but there is still room for improvement. We need to understand what are the constraints dose-wise, and we should also consider new structures. It's also important to select patients properly. There are data available regarding treatments with protons and photons, but we need to gather our own data, and we keep and we can build normograms that are properly for radiotherapy. Of course, we need to decide and make the right decisions. We need to share the plan with the patient, of course, but we also need prospective studies with specific methodologies that allow us to find a common way and to be consistent in terms of case mix and treatments, consider both the previous treatment but also the re-irradiation. Thank you.
Grazie Francesca. Prima di chiedere se ci sono delle domande, volevo chiederti un chiarimento.
I have some questions. When you showed the local control curves up to 100%, that's the progression-free, so the stable disease intended as control, which could probably also explain various responses.
Tumors, of course, are not that good. Actually, they're very bad.
Di vista, invece,
from a different standpoint, I understand that you didn't mention quite rightly that it depends not just from the first treatment, but ideally you would want to know how the first treatment was performed. And if you have a plan of treatment, that doesn't mean that a particular optical nerve has received 40 gray. Not just for contouring, but you are moving in a sort of gray area. And I am assuming that you prescribe a plan of dose, considering the tolerance. So what is the minimum dose that you administer? Are there cases where you cannot administer a minimum dose and then you don't take this in consideration? And also, how do you assess the constraints, like in a carotid, where you have an extremely heterogeneous outlook, and obviously this has an impact on its tolerance. So you find yourself having to take some decisions based on constraints which are not reliable. So my question was, how do you behave in similar cases?
Well, what we do, we don't sleep enough, and we discuss a lot together these cases. We prescribed up to the tolerance of the organ of risk, and when we go beyond the tolerance, it should be worth it. This means that this treatment should be curative, otherwise we will not do it. Many patients, of course, we do not irradiate them because we're not able to reach an adequate dose. Even though they tell me that I have to, but we don't do it.
di ritrattamento non lo considero nemmeno, so voi come vi comportate?
Well, doses are different whether we use protons or carbon ions, so of course we try to follow this. We do not retreat all patients. There was also another case, very difficult case, a girl, a 40-year-old young girl with HCC, a large tumor invading the eye. We gave her 68 grays of carbon. She was fine for 22 months. She didn't know sight loss. She was perfect. And then there was a contralateral recurrence outside the field on the other optical nerve. And this was very difficult to tell her, you can become blind, both eyes, and I will not able to control the disease. But this kind of tumor has a recurrence on the opposite side, and there can be other recurrences. So this is very difficult. You need to talk to the patient. There is not much you can do. and there is a risk of blowout of the carotid artery, but I don't have response.
With the new technologies available, we're also starting to do treatments. Now you have a very powerful tool. What margins do you use? And most of all, you base yourself on the PET and the MRI. What is your thing? Because your attitude, because the PET not always is extremely clear.
So we use this only with salivary glands, the PET. In the other cases, we use PET with FDG, and we contour always, especially with radiations, always MRI, always PET. Well, margins depend. I don't have a precise answer on what margins I use. It depends. It depends on the purpose of the treatment itself. If I use carbon, I know I have narrow margins, and I can use smaller margins. But if I use protons, I need more different margins. It really depends on this. When I was saying that we need prospective studies, more studies, they should also take into account a specific methodology. There is no specific rule. It depends also on the patients.
Abbiamo altre domande? Qualcuno vuole?
Are there any other questions? Well, in this case, there's another question over there. Marianne has said never bring the margin to 0, minimum 2 millimeters. So we need to give numbers within which we need to assess the potential toxicities, side effects, because radiotherapists such as us, people want to know, people like you want to know what margin I gave to the first radiation. If this patient should progress, I would want to know from you, what margin did you give?
Okay, very interesting presentations, and all the challenges associated with the radiations. There's a 10-minute delay. We have a coffee break now.
Valentini e Donato.
Prova, sa. Vediamo, andiamo in cabina. C'è sta cabina, è un Tetris per entrare. Vediamo, Ah, ora si sente? Va bene? Ok. Salvatore, ora è per prego. Perfetto, Salvatore. Perfetto. Prova, sa. Forse un pochino più di volume, sa. Poco perché poco di volume, un'antichiettina, sa, prova. Comincia a sentirsi, direi, in maniera adeguata. Perfetto. Proviamo gli altri? Si sente in maniera adeguata. Buonasera a tutti. Questo è un pochino più basso. Pochino, Proprio quello del presidente sembra un'antichietta, ma proprio va benissimo. Prova.
Chiedo di prendere posto, chi magari è rimasto un po' così indeciso.
Okay, we can restart this very interesting session on retreatments in SRS. I would like to express my gratitude for this session, because I'm very interested in this field. We saw Dr. Valvo before. She gave a very interesting speech, and I think this session is very important because we think, and I believe that retreatments should be followed by who did the first treatment, because of course it's much easier because we know the patient already. But if the center is not able to provide this kind of treatment for any reason, maybe the patient should be referred to another center, of course, and if the two centers communicate, we can avoid so many useless conversations and problems. And we also avoid many troubles on the patients. Patients are going to centers because they have the best technology. And this is very important because we should create a network and a connection between all centers. And if the center doesn't have the characteristics and the features of any type, of any kind, the center should send the patient to the best center for the patient. And this is very important. So let's have a look the clinical experiences, the actual practice conducted with advanced technologies, and please try to stick to the times because we would like to have a discussion at the end of the session. So I'll ask Dr. Chiesa to take the floor to speak about brain retreatments.
Buongiorno. Good morning, everybody. I wish to thank the organizers of this very interesting event, very stimulating and interesting, and thank you to you moderators. I would like to start with some general considerations. We all know that in the last decades, radiotherapy oncologists propose treatments for patients who have local regional recurrence. And I would like to start with this review that were performed by some renowned authors in order to try to draft guidelines for research in general, both intra and extracranial. With the increase of the publications since 2008, and with over 60 publications every year, major attention is addressed and focused on combined treatments and ultra-conformational techniques. One of the 30% of these works concern intracranial surgery. In August, this review was published on prospective randomized clinical studies involving re-irradiation. There are not many of them, and mainly on the head and neck. Only one of them is dedicated to irradiation versus radiation in progressive glioblastoma, with the purpose of reducing the brain proliferation. So probably the scarce number of publications could be an indication of the fear of the radio-oncologists bearing in the late toxicity. And we know this is irreversible damage to the tissue and vascular brain of the brain. And this can give rather a serious clinical framework. Generally, the lesions which are more common are recurrent high-grade gliomas and recurrent brain metastases. Now, we do not have works that have a specific evidence. I will review basically recurrent high-grade gliomas that have a relapse in up to 90% of the cases, and also they have a mainly local relapse. So we are in a picture of re-irradiation. As we can see, we have various options available, and we still have no therapeutic standard. These options include surgery, in which patients are selected, accessible tumors and good KPS, the re-irradiation with stereotaxy techniques, and also chemotherapy, second line, used both exclusively and also combined with RT, with interesting survival rates. In terms of re-irradiation, we will try to answer these questions. And the first being, with which modality do we want to perform a cranial irradiation, single fraction or fractioned? These are some of the experience in radiosurgery, which generally are referred to. These are studies which are not rather limited in terms of numbers, except for the Korea studied. Patients between 40 and 50 years old, good performance status, time of interval between radiation has quite a wide range between 4 to 19 months, with a medium volume of treatment of 10 cc. In the field of re-irradiation, these are other cases. Median age is slightly lower. We also find patients of 30 years old or 40 years old with the performance status which are very good. Medium time to re-irradiations which generally overlap single fraction, and a medium volume of 24 cc on average. Not many authors present studies with patients treated with both with single fraction and with fraction treatment. And most authors agree that it's not so much the how we administer it, but the overall result. On the left, Italian study by Dr. Maranzano's group, a treatment of recurrent glioblastoma with stereotactic radiotherapy. On the right, instead, Dr. Kuban's team, 46 patients irradiated with the single fraction 17 gray and 25 with the fraction treatment, over 15 fractions. In both studies, it is evident how the use of single fraction or fractioned does not impact on the outcome in terms of survival. Probably the difference between the two modalities is relies more in inducing the percentage of late toxicity. In this work by Choi, 2 patients do show late complications. One had a radionecrosis. Of the 14 patients with single fraction, 6 of them had also a clinical manifestation. The authors had selected patients and only started treatment to multiple lesion patients and critical lesion patients. So the survival rate was interpreted by authors in a way that for these patients, it would be better to opt for the multi-fraction treatment. But as we know, toxicity is also related to the dose which we administer for radiation, and also the dose that we have given previously. We are talking about high-grade gliomas. Let's take a look at this study by Meyer from 2008. The first thing that the authors point out is by increasing the volume of the lesion, the dose that we prescribe is generally lower. And this is that does not surprise us. Also, authors make an effort to compare this with other studies, and they confront them or compare them with the LQ model, which we have seen, which is absolutely acceptable with stereotaxy, and with an alpha beta of 2 and a total bed which adds the initial and re-irradiation, a cumulative BED, we find normalized cumulative, and it appears that NDT increases with the precision of the modality that we use for irradiation, single fraction or radiosurgery. Because in general, radionecrosis seems to appear with normalized ratios and doses beyond 100 gray, but also for slightly higher doses, because these are the techniques which involve lower irradiations of the healthy tissues. But if we were to see how doses are prescribed, it is based on the schedule in terms of dose per fraction, conventional up to 4 grays, also in the total prescribed doses. But should we summarize on the ones who are more frequently prescribed? There's a window of more frequent doses between 30 and 40 gray. This is a study by a German group, limited patient population, but interesting results. Patients treated with higher doses beyond the 30 gray have good survival outcomes, and in any case higher. But if on one hand increasing the dose can have an impact on the survival rate, it is also true that, as we have said, this can impact on the toxicity. This is a study of the Royal Marsden Hospital often cited. It's a dose escalation study in which patients from increased doses are identified for doses beyond 40 gray, the most predictive factor of onset of toxicity. This is an American study interested for the number of patients, over 100 patients, good survival rates and tolerance. Schedule 35 gray with 3.5 gray per fraction. In terms of still median total dose, generally we have doses between 18 to up to 20%. In this respect, this is a study by RTOG. This dates from the 80s and tried to give guidelines for intracranial lesion recurrence. And the level of doses identified were indicated based on the size of the lesion. And the volume is actually one of the other features we need to take into account. There's no surprise on the fact that the medium volume are higher than fractionated than in radiosurgery. We have different evidence which give to the tumor volume a prognostic role and a productive role in terms of toxicity. But the tumor volume has an issue. It is prescribed in different ways by different authors in diameters, in cc, who refers to GTV or tumor volume. So it is difficult to compare these studies. Of course, many show evidence that the tumor volume has a significant prognostic importance, but right now, to define a cutoff based on the literature is still not feasible. And also, let's try to understand what the ideal patient is for this type of therapy. Of course, the younger the best performance and the lesser is aggressive and extended the lesion is, the better the prognosis for this patient. But quite a different subject are the time interval, because here we have different indications. This is a study by the same team who did a review that I showed you at the beginning. This study identifies in a time interval as the most important prognostic factor. But we cannot take this as final data, because in terms of impact on toxicity and survival, this has not been demonstrated in all cases. Here we see the interval time, and the triangles are radionecrosis. As we can see, these radionecrosis have increased also with the passage of time. So it's not so much the time of interval, but the dose. In terms of survival rates, Fogg's study had many patients, but also took into account patients who had recurrence before the 6 months. So this was had certainly been discussed. And it must be taken into consideration, because re-irradiation is given to patients with recurrence beyond 6 months, also in terms of selecting the patients. In conclusion, re-irradiation, intracranial irradiation is a good, feasible option, and maybe a better treatment options for patients with larger tumors or tumors in eloquent structures. In terms of dose, radionecrosis often shows with doses below or higher than 100 grays as a cumulative dose. And in general, no standard schedule are confirmed, and there are different schedules with doses between 30 and 40 gray and 3.5 to 6 grays for fraction treatment. Prognosis factors and which patients, the role of there's an accurate patient selection is required. In conclusion, while many randomized clinical studies have established the benefits of initial treatment, there are no available class 1 or 2 comparative studies available. So there is a need to have randomized studies taking into account the quality of life and neurocognitive factors. What we can say is the advancement and enhancement of techniques and a multidisciplinary approach are basic to guarantee to the patient the best retreatment possible. Thank you for your attention.
Ringrazio Silvia Chiesa per...
Thank you, Dr. Chiesa, for your very interesting presentation. The discussion will be held at the end, so I would like to leave the floor to Professor Osti, and this talk will review head and neck retreatments.
So, first of all, I would like to thank the organizers, and Dr. Valentini and Dr. Donato, and all of you. I'll try to be as concise as possible, because there were the irradiation of head and neck. We need to consider a few things. The first one is that, unfortunately, these are tumors, advanced tumors, with high chances of relapses, partly associated with the type of treatment that was done up front, and the type of treatment that will also have a repercussion on the therapeutic choice. The intensification, a therapeutic intensification for this kind of diseases, is due to the fact that except for a few subsets, these are diseases that will relapse locally rather than a systemic progression. So the possibility of local control will justify the outcome of our patients. And so in order to have a clear picture, I like to start by showing you this beautiful review, which also includes a therapeutic algorithm that in case of local recurrence in patients that were treated with radiation therapy already, it is possible to perform demolitive surgery, and this should be preferred rather than radiations. So this option will only be for patients where the local recurrence doesn't allow to perform surgery, or patients that have undergone a surgical resection and have infiltrated margins, and there is a possibility of recurrence and relapses. So there are several factors that we should consider when we suppose we can perform a re-irradiation. First of all, we need to look at the patient, the age, the performance status, the presence of comorbidities, any organ dysfunctions, the need for enteral nutrition, the presence of a tracheotomy, and of course, we need to consider the possibility to perform surgery. And then also there are factors related to the tumor, the site of the tumor, the histology, the T stage, the volume, which I think is the most important factor, and also information from imaging, which are very important, especially molecular imaging. And another extremely important factor that we should consider when we think about re-radiation, we need to consider any previous treatments, if it was a curative treatment, post-op treatment, what kind of doses were given, what type of technique was used the first time. And of course, when we have the possibility to re-radiate, we need to use the most sophisticated techniques. And of course, the time frame. So a treatment, a retreatment within 6 months from the last radiation therapy would be very dangerous. And then there are also the risks of re-radiation. So acute and chronic dysphagia, osteonecrosis, soft tissue necrosis, trismus and fibrosis may cause a very a poor quality of life, carotid blowout syndrome, bleeding, pain, the need for enteral nutrition, the onset of endothelial damage and thromboembolic events, and other symptoms. This is a beautiful review from 2014, which I will refer to in my short presentation. Since 1980s, with very limited cases and very heterogeneous cases and techniques and volumes, we started to perform radiations. And when 3D conformational therapy was started, the percentage of local recurrence were very consistent between 20 and 70%, to the detriment of an onset of a level of toxicity with a fractioning, which is conventional, and this therapeutic and treatment modalities were associated with a high stake, translating into a poor benefit and poor survival, even though positive results were achieved in terms of local control, which doesn't mean necessarily a better survival. Over the past, randomized studies have been conducted regarding chemotherapy, but they were all closed, they all ended. We have our TOG study and other studies, and there is also a phase 2 study where radiation therapy was performed with chemotherapy with an incidence of treatment-related deaths of 10% and a late toxicity of 10%. So, replacement of these medication in a later study caused an increase in toxicity, especially acute toxicity. This is another 3D study, and this is by Gustave Roussy, 169 patients, and 3 different RT regimens were used, one with 2 gray per fraction, and another series of patients who underwent radiation therapy with a split course therapy technique, and another subset of patients had radiation therapy with multiple fractions on a daily basis. Results are better in the subsets treated with split course or daily treatments compared to patients treated with conventional fractioning. Good local control results and poor results in terms of changes in the life expectancy of patients without 2-year survival, very poor. This is the original study from 2008, where fractions of 2 grays 5 days a week with an interval of 9 days between groups associated with concomitant chemotherapies. The results, there was a median 11 months survival and a 3-year survival of 22%, a good local control with an incidence in almost half of the patients with local regional, 29% of metastatic recurrences. And with regard to toxicity, 19 patients died because of tumor-correlated causes. 130 patients in this study. There is a comparison between observation and retreatment, and we see that the retreatment has benefits in terms of local control, but not benefits in terms of global survival. The same applies to the re-radiation performed after surgery. So the improvement of techniques, the use of MRTs implies better results. What happens here is that there is a reduction in the toxicity. These are all studies with limited patient populations, with the contouring of target tumors is quite homogeneous. The levels of the doses are quite different, but not benefits in terms of outcome, but in terms of toxicity. And then there is a further evolution on the use of the SRS, so stereotaxy. A hypofraction treatment is used in 5 fractions of 8 gray. And this is a very interesting study from the University of Pittsburgh, where radiotherapy is associated with chemotherapy, with cetuximab, and 3 cycles of cetuximab, as you can see in the survival curves, causes an improvement in the results and outcomes. Other studies confirm the validity of fractioned stereotaxy, and we should consider the volume and the level and the dose level. So, similarly to the central nervous system, the volume for head and neck tumors is a very important prognostic factor. There is a lack of consistency in terms of on all systemic chemotherapy treatments that should be associated with the therapy, cetuximab or other molecules, or other molecular target drugs. With variable results, this is a multicentric result published in 2011. As you can see, there is a local regional response of 80%. So, these are images showing a complete response after stereotaxy. This is another study with the use of the CyberKnife, same results, with excellent local regional control, and survival rates are still not too high as expected. And volumes are different. There are different expansions, and also the dose levels are consistent and heterogeneous. And this retrospective comparison with a vol study published concerning head and neck cancers, in terms of local control, stereotaxy, fraction stereotaxy, associated whether or not with systemic therapy, proves to be the best. Stereotaxy, which has also been used postoperatively on patients with a residual disease and good local control. These are my conclusions. So, when we want to re-irradiate, this is very important. Time is very important. Proper selection of patients is also important. And then study with accurately previous treatments. This group is the perfect group to share the therapeutic strategies when we have to decide on re-irradiation. And we're talking of diseases with a local recurrence, so there is a justification as long as there are the clinical conditions. We need to bear in mind there is an improvement in terms of local control, but there will also be an increase in toxicity, which can have an impact on the survival of all our patients, not only their quality of life. So it is mandatory to use the most sophisticated technologies when we perform re-irradiation. And in my opinion, stereotaxy, fraction stereotaxy, is the best tool we have for this kind of treatment. And we should also bear in mind that this kind of treatment with high doses can cause an increase in toxicity. Thank you very much.
Grazie. Grazie mille, Mattia.
Thank you, Mattia. Very good presentation. We'll now give the floor to Professor Muto, and he'll talk about lung retreatments.
Grazie, signore. Thank you, ladies and gentlemen. Thank you to the moderator, and thank you, Piercarlo, for giving me the opportunity to reviewing this topic with my colleagues. And it's important to have an occasion such as this, in the sense that here in Italy we continue to create radiotherapy divisions on the first floor, on basements, because I've learned a lot yesterday that in 2,000 patients, lung patients in Pittsburgh, either they do not have a thoracic surgery, or from the higher levels there's radiations fleeing from above to the neurosurgery. And you have the thorax surgery that don't work too much. So this puts us in the conditions to work more on these methods and on this situation. And colleagues before me, and also yesterday, like Dr. Genovesi, who spoke about a common language and raised the matter of a certain confusion, should have an impact on us in terms of talking together once and for all. Everybody has said that we need to listen to the opinion of the patient, hear the patient, because it's the patient who finally decides what he or she wants to do, if he wants to go with the risk of radiation. So it's important to select the patient. So if we take a look at this first slide, background, the techniques have allowed us to improve the local tumor control and also improve long-term survival. But this goes towards potential risks of recurrence. And this puts us in the position with all the imaging techniques to, as Professor Gualdi said before me, how and when to indicate a recurrence versus a post-treatment fibrosis. But however, this does raise a lot of unanswered questions, such as the possibility of the radiated area has not forgotten, so to speak, the tumor. So to bear in mind this continuously. And Francesca Balbo mentioned this, the need to see the previous plan of treatment. And Vittorio Donato underlined that it should be the same center that treated the patient for the first time to treat him or her again. A series of considerations basically bring us to understand if there are any resistant traces of cells in this treatment. Therefore, it is obvious that we are hesitant to re-irradiate and ask ourselves why we need to take on these patients in a selective selection, treat them, because in any case these are complicated patients. We will have a complicated plan of treatment. We will be faced with a lot of work, and we need to bear in mind the potential toxicity of the treatment. And overall, probably it's easier to say no instead of going along a very cumbersome and the fear that can also that we can also have. But despite this fear, the American guidelines have started to provide some indication on, especially in this 2016 version 4. This is a definition of what to do in specific cases, but this is done given a treatment that must look forward and look towards the quality of life. Treatment must not go against the quality of life of patients. It's a very unstable equilibrium, especially in the lung. We see many patients after chemotherapy or radiotherapy have 50% of two lungs still functioning. If we continue one dose extra, this could be lethal for these patients. So when we evaluate before retreatment, there are three pillars that are, first of all, the dose, where we need to know what has that patient received before, the time, in the sense that what time has gone between the two courses of RT. And most of my colleagues have reminded us that this must be at least 6 months for all organs, and also the problem of the volumes. And at the same time, the intent, the rationale of the retreatment. We need to look the patient in the face and discuss what the intent is. And finally, assess the general conditions of the patients, because if we just assess the documentation, we need to look at the patient and review his clinical situation. Suggestions for retreatment. For the lung, many have said this before, the target definition is key. The choice of the equipment, the association with the new drugs which can enhance the response to treatment. Suggestions for a treatment. This has the difference between tracking and gating has already been reviewed. So which technique for re-irradiation? We've heard previous speakers this morning, protons, but what does literature tell us in terms of doses? We certainly haven't searched for many articles, but two which I would like to bring to your attention. The first published in Lancet, and this highlights the previous treatment, the dose, the new treatment, the initial dose with a 3D CRT and protons in a conventional form. And this is first author is in the room today, but this is an extremely interesting study in which the dose is compared between 3D and stereotaxy treatment, where you see, you can see this is a review that studies not a high number of patients, but what is important is how the treatment, conventional treatment, was repeated over time with the stereotaxy treatment, and the outcome was a survival rate, which we will see. Or this other group published this study, SBRT, was followed again by another SBRT treatment with different doses. But in actual fact, in terms of the reduced patient population, doesn't tell us that we need to lay down in stone this in terms of guidelines. But at the same time, this is the Lancet study I was mentioning before. These are the clinical results, the 3D compared with the 3D, and 3D compared to proton therapy in terms of number of patients. And this is the Bernardino's study here, overall 3D versus or going towards or compared with the SBRT, overall survival at 1 and 2 years. These are still clinical results for local control and overall survival. These are slightly less good results. Toxicity. Again, what we see here is in some cases it was well tolerated. In others it showed pictures which were slightly less good. And this is a fistula or pneumonia or bleeding. Comparison between 3D treatment and stereotaxy treatment. Again, this is the toxicity. What we can say here is this pneumonia for a central picture. So what considerations can we draw upon this? Is that the number of patients was often limited, that most of the published studies did not report any data about PTV volumes, which would have been a crucial point, and that many have told us about the margin of the lesion. And also the patient selection criteria was not always clearly stated. And it was a relatively short follow-up. Therefore, this is yet another issue that should be reviewed in terms of having more long-term results. So between different total dose, fractionation, and volumes definition, everybody gave a different margin to this volume to irradiate. So at the end, we don't have a homogeneous picture. And this is something that many speakers have said yesterday, like Domenico and others, the different dose prescription. This truly becomes a key point on which we need to still work in order to define the prescription, which is the same in all cases with specific, what we give in Naples is done in France or in Perugia. The different clinical situation versus a different location of the lesion. So the regards to toxicity, I will go rapidly. This is our experience from May 2016. We have exceeded 1,000 patients by now with treatment with Cyber, which 204 were lungs and just 11 retreatments. This clinical case is 2013, a first treatment with 48 grays in 4 fractions, followed by a PET with SUV of 6.8. October 2014, stable. And at the end of 2015, we have a retreatment with 40 grays in 5 fractions for this lesion. SUV remained unchanged as of June 2016. So in conclusion, while you read these conclusions, I would say that never give indication to a retreatment based on the documentation. So always look at and talk to the patient. Speak clearly with the patients on the purpose of the treatment. The medical team and physicist must be expert and must have a familiarity with the methods and with the equipment. It's easier to say no, but if you say yes, you must transmit to the patient the certainty that he is giving himself to you in full faith, but this is not a guarantee, because the guarantee is something that is quite apart, quite different. Thank you.
Grazie Paolo, specialmente.
Thank you, Paolo, most of all for your clinical considerations, which and for your conclusion.
To introduce and invite Alina Mihai. Yes, okay, good. Her presentation is retreatment on abdominal metastasis. Please.
Yeah, so first, thank you for inviting me, and it's
Prima di tutto, grazie per aver
sign in front of our and technology is all right. Technology is good when it works. All right, so as you heard so far, it was a lot of reluctance in retreating patients who previously received radiation, and probably this topic with abdominal oligorecurrences is one of the most challenging. We have now data in brain, we have data in pelvis, a lot of data, thanks to you, by the way, congratulations. We have data in lung and head and neck. But it seems to have been a lot of reluctance in treating abdominal oligorecurrences. Now, what we know is that the most common sites for where we will see abdominal intrarecurrences are the pancreatic cancer, colorectal, esophageal, gynecological, and renal cancers. And I think that with the advent of radiosurgery and new technologies, in addition to the in-field and marginal recurrences, we see now a new group of patients that probably we are going to see it more and more often over the next few years. And this is an example of a patient who was sent to us with oligorecurrent colorectal cancer in the adrenal and liver. We gave her radiosurgery to both sides. And then 1 year later, she came with another liver recurrence. First question is, should we treat? Second, how we treat? And not the last, can we treat her, really? And I will come back to this one later. Now, as you heard already, the decision to retreat a patient should involve a multidisciplinary approach, because these patients are patients who have very limited therapeutic options, had previously received multimodality treatments, and in my opinion, I think that retreatment at this point in time should be limited to patients who are unsuitable for other treatment modalities. When we decide to retreat, we have also to think what is the aim of the treatment. And it's very important to define, is this symptom control alone? Do you want to prevent symptom from progressive disease? Or do you want to treat with curative intent in patients with oligometastatic or oligorecurrent disease? You already know that there are a few factors to take into account when we retreat patients. And in two reviews, one from Canada, one from Japan, they surveyed in Canada 183 patients, in Japan 18 centers, and what they found was that in fact it is a lot of reluctance to treat. This reluctance is less with the advent of new technologies. However, and the factors that are taken into account, as mentioned already previously, are patient-related, tumor-related, and also previous treatment-related, and also what life expectancy the patient has. Now, as I mentioned, it is very little data in this setting, in the abdominal setting. So the conventional radiotherapy, I found really 3 studies. The first one was published in 2009, very small number of patients. Most of the sites are pancreas and colon, and the median interval of time is over one year. First course, the median dose is classical, and the dose used for irradiation is either in hyperfractionation or standard fractionation. The IMRT is used, and the local control and survival are difficult to compare between the 2 studies. However, what we can see is that you can have up to 50% local control and very limited toxicity, around 10%, which is the toxicity also seen in the primary setting. I will draw your attention to this study, just published. This is a very, very nice study in 36 patients with hepatocellular carcinoma who received ray radiation using IMRT, quite large tumor volume. And what this study shows, and this is what we have to remember in treating patients with oligometastatic and oligoprogressive disease, what this study shows that is if you don't have enough functional reserve in the liver, meaning at least 700 cc's of liver to be spared, you can kill the patients. So patient selection is extremely important. Now, the patients with oligometastatic disease are quite different of the patients with hepatocellular carcinoma, but I think that in the context of seeing patients with retreatments, we have to remember this. The functional reserve of the liver is extremely important. Now, why should we use stereo in this setting? Just because we have it? Let's see. So we see here that the dose distribution, and we know it already after these 2 days, that we have a highly conformal dose distribution. So what do we expect? We expect that these patients will have lower toxicities because you will have less radiation dose in the neighboring organs. We know that the reported outcomes in the primary setting shows very high local control of these tumors and very little toxicity. And we have now data, and you've seen some of it, with the ray radiation in the brain, head and neck, thorax, pelvis, which shows encouraging results. In patients with abdominal recurrences, these are patients who underwent multiple treatments. These are patients who are most likely symptomatic, so they will have very poor KPS. So in this setting, until the stereo, which is minimally invasive, so short overall treatment time, is more suitable for patients who are not candidates for other treatments. However, the benefit of a very tight dose distribution can be also the double sword. Because if you have, this means that you can have potential geographic miss, and you can have unwanted irradiation to the OARs, and instead of having lower toxicity, you might end up having a higher toxicity. So we have to be very, very careful. What is the data on ray radiation? Most of the data comes from the pancreatic oligorecurrences. Why? Because 60% of up to 60% of these patients, even when they have previous R2 resections, will have a local recurrence. These patients usually are symptomatic and with poor quality of life. The treatments are very, very limited. Very few are amenable to surgery, and if they have surgery, the side effects are significant. The systemic treatments have poor response and high toxicity, and the conventional external beam radiotherapy is limited by the tolerance of the normal options. So the stereotactic radiotherapy seems to be an option to consider. Now, I found only 3 studies in the literature, most of them coming from Stanford, looking at patients, a small number of patients, less than 20. Most commonly used dose is 25 grays in 5 fractions, short follow-up. However, what they show is that even in this recurrent setting, in these patients, you can achieve very high local control. The toxicity was limited, around less than 10% again. Most of these studies used CyberKnife with tracking, and most of them will use the PET-CT for the target definition. In all these studies, the PTV equals the GTV plus about 5 millimeter margin, so you don't do any expansion for the CTV. Now, this comes back to the patient selection that you heard already before. So this shows that in patients who recurred more than 9 months after the previous treatments, they have significantly better survival and progression-free survival comparing with the ones who recurred less than 9 months. So the question is, should the patients recurring less than 9 months be even treated? Or what is your aim of your treatment? For other sites, the radiosurgery is not really used. Like you will see that very small number of patients, again, usually reported as part of other cohorts. Again, CyberKnife is most used. The tumor size is quite small, but up to 1,000 cc's were treated. Again, limited follow-up, good local control. But what these studies have shown also is that we can have significant toxicities up to 15% grade 3 and grade 4 in abdominal tumors. They seem to be higher for the pelvis than the abdominal tumors. And they also show that in patients who are symptomatic, 96% of them tend to respond to this treatment. Now, so overall, what I found in the literature was that ray radiation is possible. We heard this already. Technically, we need multimodality imaging for target definition. You need motion management, otherwise you cannot treat. Mostly the tracking, but also gating were used. In this setting, GTV equals CTV, and the most commonly used dose is 25 in 5 fractions. In terms of clinical outcomes, is efficient in symptomatic relief and seem to have a low rate of toxicity. However, all these studies are retrospective. All of them have very small number of patients, and all of them have limited follow-up. So these results have to be questioned in this context. We have lots of unknowns, and these are the challenges of this ray radiation. One is the risk of normal toxicity. So you heard already the previous speakers that we are afraid of what is the toxicity in the setting of ray radiation. We don't really know what is the impact of very high doses of radiation in these patients who already received previous radiation. We have a limited follow-up, so the late toxicities, you are not going to see them. They can be more than already described, but with a follow-up of 5 months, I don't think that we have enough data at this point. Another issue is the organ motion and organ deformation. I think that this is very, very important in abdominal tumors. Then I'll spend a little bit how we account for previous doses, what DVHs should we use. And I don't know how it is in Italy or somewhere else, but in Ireland we have difficulties finding the previous records and having enough information about what dose the patients previously received. Now, motion and deformation. I think that you already know, like most of you must have seen this already. We know that the abdominal organs move, all of them, including kidneys, pancreas. We know that most of the motion is in superior-inferior direction. And we know to manage it, or we think that we know how to manage, the liver. We don't know pretty much anything about bowels, kidney, how can we manage them? So these are important issues. This slide here, unfortunately, doesn't project very well. What it shows is a patient who was sent to us for stereotactic treatment in the liver. She had a CT simulation, empty stomach, and half an hour later, she had an MRI for planning. Empty stomach again, half an hour between them. What it shows is in pink was the contour before, like half an hour earlier, and in dark blue here, the small bowel, you know, like just the same day, 30 minutes apart. So this can impact on your dose distribution, and this is just between, in the same day, the same, like few minutes apart. What happened, how do we account for the deformation which happened between the 2 treatment courses? We don't really know. Can you control the peristaltic? No, really. Now, this can play in our favor by blurring the radiation dose, but this also means that you don't really know the dose which was really received by the organ. So this can be an issue. Now, we spoke about liver deformation and what we want, what we know how to do.
We have 2 minutes.
Yeah, I will finish now. So what is happening, you can use fiducials and gating. So you beam on during certain times. Other teams use deep inspiration breath hold. However, in this image, you can see contour between CT and MRI. Empty stomach, deep inspiration, same amplitude. And in this slide, and expiration breath hold, where the contour of the liver seems to be the most stable. So I think that you'll have to decide what treatment management of respiratory motion is best for your team. This image, again, everybody knows abdominal compression is used. On top of being not comfortable, what you can see is that you can, depending on where you put the compression plate, you can have deformation of the structures. What dose are you delivering, you don't know. Now, how do you account for motion is no recipe. We don't have outputs for those matrices. The deformation of the anatomy is not taken into account. We have no clear information of the Dmax of previously delivered doses. And we know that equivalent dose calculation has limitations, very high dose per fractions. Do we have a guideline? Not really. The studies use different dose volume constraints, either Dmax or some kind of volume. What we know from the pelvic sides, most likely is that the rectum, the bowel can take up to 110 in dose equivalent. So keep this in mind that we don't have any guidelines. The kidney is even worse. We don't have any data. Everybody uses V20, less than 33%. However, we have no clinical data in radiation setting. We have only data in animal models from 1990. We show that, in fact, the kidney does not repair, the kidney damage progresses. So keep this in mind, because this was a surprise for me too. So in summary, I think that what we showed that is that SBRT can be used, can achieve high dose of local control. There is a higher risk of toxicity. The decisions should be based on an MDT approach in patients who are not suitable for other treatments. You need to minimize the margins of your target, and you need motion management. Otherwise, I don't think that you can do it, well, somebody must be crazy. The tolerance to SBRT, to radiation, and dose volume constraints are not defined, so we need more studies, we need guidelines. Patient selection is extremely important, and I think that at this point in time, I think that we have to be really cautious how we approach this kind of patients. And thank you very much for...
Thank you. My compliment about your brilliant exposition.
Thank you.
Okay. Chiamo adesso qui.
We couldn't end with a better way with Professor Fossa. She's an expert on this topic, retreatments for prostate cancer.
Pomeriggio. Sono arrivata in ritardo, ma spero che riusciamo a finire per ora di pranzo. Devo dire che è un compito anche difficile.
It's a difficult task, because I'm the last speaker before our lunch break. The program today is extremely interesting, and I'm very glad to be here. I'm here today to talk about retreatments for prostate cancer. If I can have my slides, please.
Le ho viste prima, vado io? Ok, perfetto. Ok. Allora, urologia, come sappiamo...
The urology, as we know, is a part of our daily practice, and 25% of our patients are urology patients, and most of them have prostate neoplasia. We do curative RT, post-prostatectomy RT. Then we have the group of oligometastatic patients and palliative treatments. We don't have much data on recurrence after EBRT. We have organ-confined cancer, and we know that recurrence is only visible after 5 to 10 years. However, the 30% of the patients can have a local recurrence. This is rarely reviewed, but until a while ago, patients with just biochemistry recurrence started hormone treatment. So we have many issues in terms of the type of treatment that the patient has received, recurrence, relapse, with the issue of the imaging, which is changing year by year, and we always have new novelties in this area. This is a study from Finland in 2014 that reviewed and studied 160 patients. As you can see, with PET choline, local recurrence, if we take a look at all the patients with biochemistry recurrence, actually 2/3 of the patients had a interprostatic recurrences. So it is a issue that was being slightly overlooked, although it is frequent. Strategies in local recurrence. Obviously, as a colleague said before me, selection is key. Patients with post-therapy recurrence must be divided in these two main groups, either candidate for local approach or not candidate for local treatment. These are the most commonly adopted guidelines. And the latest IRO guidelines also review this. Patients with non-aggressive, so initial stage disease, T1 and T2, confined to the prostate. The life expectancy is also important, should be at least 10 years, and PSA at recurrence, also important. Imaging is important because the patient has a local or diffuse disease. We have new tools available beyond CT or PET with choline and PSA. Not yet validated, but it is a new tool. We've been talking a lot about the whole body MRI or the one-stop shop, which is a test which does the PET with choline and MRI, so we have a more precise information. So patients in which we do not have distant metastases, we have local recurrence, and these are the strategies that has to be discussed in the guidelines. Again, one of the options is the observation alone, based on the life expectancy, type of disease, which is still an option that should not be overlooked. Salvage surgery, cryotherapy, and brachytherapy, which is somebody talk about as interventional. These are surgical data. We have found, this is a recent work by our surgical team that reviewed 27 retrospective series of salvage surgery. These are the details, and I will not go into them. What I would like to highlight, from 11 to 400 patients, what we do, what I like to highlight are complications after salvage surgery, and we know this very well. Unfortunately, the biological price is high. Damages to the rectal up to 20%, anastomotic stenosis up to very, very high levels. Also, with mini-invasive or robotic salvage surgery, these numbers go down by small numbers, but only little. The same goes, if not even worse, because our group has started with salvage cryotherapy, but stopped after some rectal fistulas. This is a relevant issue, up to 5% of rectal fistula. This is based on experience. In terms of brachytherapy, salvage or prostatectomy, it is evident that in terms of biochemical control, we are highly competitive, because on the left, this is the surgery, on the right, the brachytherapy, and the difference is a level 4 of evidence, but it is a consistent difference. This is a literature review from some of the authors are here in the room today. These are the therapeutic options for these candidates. As always, various options. Systematics in terms of hormone therapy, and then data on local therapies. These are the numbers for salvage brachytherapy, and more or less constant result of a percentage of patients with no biochemical relapse, more than 50%, which is an important number. It means that these patients for at least 5 years are free from treatment, which drug holiday, as the oncology calls it. So it's a long retirement from medical, or should I say, drug retirement. So it is an important data, and rather constant in all the cases which we reviewed in this study. In a similar aspect of focal radiotherapy or partial prostate irradiation, for intraprostatic limited recurrence. And with the new diagnostic tools such as MRI, this plan is more and more feasible, although we need to understand the validity in terms of, or in comparison with the whole prostate therapy. As you can see, the guidelines show that there's only brachytherapy. So somebody asked themselves, can we also do an external beam radiotherapy? And for analogy, we can assume that given that brachytherapy is not the same, but there are dosimetric data which can be overlapped with external beam therapy, such as SBRT with HDR. These two treatments are similar, and this is one of the first studies that compare the two treatments. For analogy, we can also talk about external beam treatment for salvage treatment. Obviously, the tools today are multiple. Unfortunately, as speakers said before me, these are just a retrospective study, so low level, but unfortunately we are in a scope of customized therapies, personalized therapies, and for this reason we should go towards first and second level confidence data. This is just one case, one patient after NED at 6 months, never over 30 patients, but with external beam up to 35 gray for total dose, using CyberKnife, EMRT, SBRT. Little brief follow-up, but data can be compared with those of the brachytherapy. This is a work which has been submitted. This is a poster, cases at our institute, 40 patients with a retreatment with a not highly selected, no patient with low T diseases, because our surgeons and oncologists and patients prefer this treatment with low biological cost, with a perspective of a drug holiday, which is a rather holiday. And we have 60 patients treated with 30 grays in 5 sessions. And this has a follow-up of 20 months, 50% NED at 2 years. This just to give you a picture of some plan of therapies in order to underline that we should use the most selective therapy treatments possible. So discussions on a case-to-case basis. If we need to treat just the prostate or other nodules highlighted by the MRI, this based on the comorbidities of the patient, on the age, on the patient, on the previous treatment. So it is a personalized treatment. It is mandatory to use the image guidance, the MRI with all the issues with the fusion and previous fiducial markers. With the fiducials, it's not always feasible, and it's also not always simple to decide for a new treatment. But I'm not sure we have treated 3 or 4 times. One patient was treated with CyberKnife. It's a case report, so there's no evidence here, but it was a very interesting case in terms of the history of the disease. Again, the MRI shows us the nodule very clearly. Unfortunately, the back of the prostate is less visible in terms of planning. This is a patient who we treated 4 times and has a recurrence every 5 years. It's very, very particular. he's also cardiopathic, so we have retreated this patient most times, and every surprising response. But the volume is very small, so we work, as we always say, on the volume. The smaller the volume, the more I can raise the dose. So in this case, the cumulative dose was rather high, and the patient has shown no signs of toxicity. The volume is slightly larger here, half of the prostate, and this is based on the size of the disease and the extent of the recurrence. Other cases, such as this, that we can treat with a post-op salvage surgery. This is difficult because this is sort of a virtual area between the vesicle and the rectum, and it's rather difficult in terms of planning the therapy. We have 3 out of 4 of these studies are Italian, patients treated on the post-op bed. Again, these cases we never see toxicity or relevant toxicity, close to 0, which brings us to think that there is room for dose escalation because toxicity, luckily, was not found. Cautious planning is mandatory. This is a study done with the study of Dr. Beltramo. These patients were treated with the CyberKnife. And Dr. Bossi is here, and she's well aware of this study. The dosimetry in patients treated with salvage radiotherapy, no one had toxicity, so we saw the average doses or the mean total dose. And we intended these as safe doses. We have no G3 and G4 events to correlate. We have doses which in patients treated 5 years ago created no G3 or G4. So this is how we proceed in this difficult field, but we are rather confident in this respect. This is a scientific letter, a warning paper published by a Swiss group. Here, patients were treated with a 2D radiotherapy and then retreated with, unfortunately, with the majority with a 3D radiotherapy and brachyradiotherapy, rather high doses on the entire prostate, and had high toxicity. I think that 50% were G3 and G4. So this is an important message in order to use technology, sophisticated technology, and selecting patient, which in this case is mandatory. Final slide. I apologize for the delay. I shall end by underlining that we have many BRD series, and we have first promising EBRT reports in terms of toxicity, which is low, and high efficacy. It is certainly a good option for highly selected patients. It is highly competitive to surgery or systemic therapy in terms of tumor outcome and toxicity, and it's our priority is the best available approach should be employed. Thank you very much for your attention. I'll be glad to answer to your questions after the coffee break.
Grazie, abbiamo
Thank you. We have limited this session to the presentations because if Piercarlo, we will have 50 minutes of discussion, also because we started 15 minutes late. So I wanted to thank all the speakers today because they have done a really excellent job touching on all the topics and issues. Obviously, we have two settings of patients. Patients who, like Barbara described right now, who have a long life expectancy. They can go on holiday from drugs. And other patients for which, if you try to look at the median average survival, went from 12, 18 months, and even less. So in addition to these two groups, the weight and the importance of toxicity is extremely different, because if you have a patient and you offer 8 months of overall survival, 10 months, when they do fistula and toxicity, obviously the therapeutic weight, therapeutic load is not proportional. And again, we know that Paolo expressed this message very well. We are faced with patients with whom some of them are aware of the person who treated them before, failed. These are all patients who received radiation. We didn't monitor the disease, and now these patients are told we want to pursue with this therapy. They could say, well, you didn't get it right the first time. Why should you make it right the second? On other patients acknowledge a great level of fear and do not want to surrender. They still want something. Then they put themselves in our hands. They want something else, and they help that this can come in situations which are not disproportioned to their quality of life. So we are faced with different cases, including fear and lack of faith. So it's a situation in which it represents a challenge for us, clinicians. Everybody has said this today. We are faced with the need to do something, because this technology we have seems to be an opportunity to not overlook for these patients. On the other hand, we should never overlook, and everybody of you underline this, how much this technology is not always managed to guarantee the fact that we can minimize the side effects, because we have movements, because the previous radiation can give problems in terms of reporting. We can say this between us. Reporting gives a picture of a CT scan done before the entire therapy. So it's not a cumulative dose. It's not a cumulated dose. It's an assessment of what we would want to do. And we don't do corrections for cone beams or for portal images. So we move upon assumptions, and on those assumptions we re-give doses, and we know that we are entering zones at risk, changing the fractions. So we do enter areas at risk. So I think that the speakers have given us a clear picture on our uncertainties, the fears and the risks and the requests of the patients, and some clinical scenarios which are different. Of course, head and neck, brain, lung, superior abdomen, upper abdomen have a different history than the prostate. In this framework, if you want to pose questions, these have clarified, and then I'll stop after this. The cutoffs are unclear. No cutoff in terms of volume. Cutoff of time depends on the patient. It's early or late recurrence. But it is a span, it is a range. There's no precise cutoff in terms of doses. Again, I've already commented on the uncertainties we still have. And last but not least, the issue of having a general oncological picture, because many patients don't come to us for re-irradiation virgin, so they're already done sequences of drugs, as Elvia Rossi has mentioned before, have a license of use because they do not give toxicity systemic, but they never mention of innovational drugs if they give radiotherapy toxicity, because those are not taken in consideration by the Italian Drug Agency, and then we find issues after that. So there are additional variables that are not often mentioned, but these patients have the right to have an opinion from us, so we have 10 minutes to discuss this. I leave the floor to you.
Commento, Vittorio, casomai.
Sono domande dall'audience?
Any questions? So what Vincenzo said is right. I think that there is another scenario. The prostate can be studied, PET, MRI, all these tests indicate if we have a focal disease, there is a possibility to perform a biopsy. There are also to insert fiducials that allow us to be very accurate. What do you think? Should we push towards partial treatment or retreatment?
As I said, it's a personalized approach. Initially, we need to start. We started with the prostate for retreatments. Recently, we are starting to move towards partial treatment, focal on the recurrence, because we have the MRI, which gives us specific limitations, and in many cases, the PET has a different resolution, but does show us the disease from one point of view. So we prefer to increase the dose 6.5 or even smaller.
Sì.
Dobbiamo spegnere noi
prostata.
So talking about prostate, we have a disadvantage. Our PSA is never zero after radiation therapy, or it takes a lot of time. How do we judge these patients? What do we do with a PSA, which is a very simple element to keep these patients under control and to monitor them? And then we have all these kinds of investigations and tests. Even the biopsy at 2 years after radiotherapy has a high incidence of positivity. So maybe we should be very accurate and prudent and in the definition of this kind of disease. What would you do?
Well, naturally, you're referring to the PSA after the first treatment. So, if I understood correctly, was this your question? Not after the salvage treatment. Well, we use criteria of the Astro, which date to 2005. I must say that today, in patients with a rapid increase, you need to study them better. I think that I rely on this I'm rather confident. But if you take a look at the distance, the interval between the first RT and retreatment is 5 to 7 years, up to 10 years. Patients who have had, in any case, a good biochemical response. If they've done hormones, this is zero. So I have doubts on persistence versus a new recurrence. I do not see these cases too frequently.
Abbiamo
Yes, Still talking about the prostate, just one last remark. Some methods like cryotherapy or IFO, which are often proposed and suggested to our patients, they demonstrate and they prove to have significant side effects. But this is different from radiation therapy, which seems to be different. So having gathering data would probably support this method, which is usually very well tolerated by the patient. You mentioned 4 treatments, but there is, I think, room in this field.
Okay. Pose one question to Dr. Chiesa on the head and neck. Dr. Chiesa, a question which was posed to me during a previous meeting. And you know that oncologists do not agree on brain retreatment. Do you see complications after treatment? Do you see late recurrence, late complications, retreatment associated to chemotherapy in head and neck? We need to be extremely careful on the dose. Can this give us a correct judgment on the dose? Association with other drugs, does this give us a clear picture of the dose?
Actually, yes, it's possible to see them. Survival rates are around 8, 12 months if we associate this with the chemotherapy. But this, of course, can improve. So if we consider a median time of 8, 12 months, this is possible, yes.
Obviously, a question, and you already have the answer. Vittorio, I have showed a data and I kept the same schedule of radiotherapy and doing cisplatin and paclitaxel as chemotherapy, and these had a doubled toxicity. Therefore, it is obvious that the main issue is head and neck are used little. And Professor Valentini said this, the new drugs, associated new drugs, which give toxicities which we did not envisage. And the rationale of the use of the cetuximab from a systemic point of view has a lower toxicity. So probably he could have found its collocation, its in association. And then looking towards the future of the immunotherapeutic agents, because that change and local change in the immune system, also spurred by local radiation, could find a positioning in association with immune drugs.
Bene.
Okay, I think we should be very grateful to all the speakers for their presentations. And I'm also thankful to Vittorio. I want to express my gratitude because Vittorio pushed me out of some groups, and now is supporting an initiative that might help all of us find some cutoff value in terms of volume, time, doses, based on this idea, on the idea of sharing data efficiently, so that we can make comparisons and provide further evidence and try to solve some of the difficulties that we've seen. So he's supporting this initiative, and I'm thankful to him, and I'm thankful to Piercarlo. Thank you, Piercarlo, and enjoy your lunch.
Prova. Prova, prova. Funziona.
Io direi di iniziare i lavori anche che venerdì pomeriggio.
I think we can start because it's Friday afternoon. So, Dr. Marchetti should arrive soon, but we'll start anyway. So, Professor Filippi, Dr. Filippi, please, you can come for your presentation. Marchetti è bloccato in aeroporto.
Quando vuoi cominciamo, per me. Ok, buon pomeriggio
Good afternoon. Thank you, Piercarlo. Thank you, UPMC, for your invitation. So we'll talk today about the combination of radiotherapy and an immune checkpoint inhibitors and the rationale and clinical development. And actually, there are also some other chapters, but I will focus on checkpoint inhibitors and the possible interactions. So there's a possibility of balance that is possible to obtain with the immune system. This is called cancer immunoediting. And as the tumor progresses and becomes less invisible to the immune systems, some clones are developed and develops. So the majority of malignancies have still some immune activity, but this activity very often is off. It's not working, so it's not possible to control the disease. So this discovery is quite recent, but it's very crucial in the development of therapies and combination with the radiotherapy. So data on the colorectal cancer and immunoscore, which has been developed by a French group, very promising, and it's possible to predict and select what tumors are more immunogenic. So it's possible to personalize treatments with regard to this kind of therapy. So it's a new concept, it's a new idea. There are several steps. And the relationship between the tumor and the immune system is very complicated. Out of all these steps, we see there's some different factors, stimulating factors, inhibiting factors, but they can be changed by the radiotherapy. The first one, as you can see on the slide, It's a type of release caused by chemotherapy or radiation therapy. And you see basically there are two types of cell death that are differently immunogenic. And this is what we'll try to focus on. And on the other side, there is a series of modulators that increase or stop the possibility of the system to see T cells again, and the primary activation that happens within the lymph nodes. So we need to be a part of the system that is active, and this is important for the interaction with the radiotherapy. And then the activated T cells should reach the tumor site, so there should be an efficient permeability, and then we should have an infiltrate and the recognition of cancer cells by the T cells, and then the cell killing mediated by the cells. And this can be inhibited by a series of factors, and one is the main target of the most important drugs in oncology on different type of histology. So in checkpoint inhibitors, we mean a class of medications that inhibit or accelerate this process, and they inhibit and they allow to release the brake or push the accelerator to push forward the immune response. The first demonstration that radiotherapy was able to obtain immunogenic cell death is quite recent. There are some features which are very well clear, and it's the release of ATP, HMBG1, and carnitine. All these three features are typical of a cell death which is activated by the T cells, and radiotherapy is able, and this has been confirmed by several studies on animals. So radiotherapy is able to produce them. So the first step, if radiations are able to trigger immunogenic cell death, has been demonstrated, and it is clear. So different fractions, we're able to trigger them at different levels. And this is the first step of the process. The second step is to understand if radiations can increase the possibility of activated T cells to migrate towards the tumor site, locally irradiated, and this is true. It has been demonstrated on breast cancer on animal models. These are very important data which demonstrate that after the therapy there is a release of signals which are signs of carnitine that activate the tumor site, and this is essential for the interaction with immunotherapy. The third step is the interferon to create a microenvironment that favors this activity. It's essential for the infiltration and for the target recognition and for this tumor-specific activity. And radiations are able to produce interferon gamma and favor this macro environment. Another mechanism is the cross-priming. So the possibility to represent, and so that the dendritic cells represent, and T cells that are sleeping can reactivate. Some T cells are exhausted and consumed, so they have no immune activity. The possibility to have cross-timing allows the system to restart. Radiations do priming, so to speak. They are also partially able to activate new antigens. So on one hand, we have an already activated immunity, which is reactivated by radiations. On the other hand, we can be more effective in terms of priming. This translates into a concept that has been developed by Formenti and De Maria. So it exploits this effect after radiation therapy in favor of the immune system against tumor antigens, and this is inhibited by a series of factors that are negative regulators. First of all, the infiltrates of T cells and TG-beta. So what happens? We have a microenvironment that is activating but also inhibiting. The balance is also modified by the possibility to have an increase in vascular permeability and in the attraction of T cells, of C cells in the tumor site. FAS and NAKG are the main elements and the antigens present. So the ability of the tumor to present antigens. And bear in mind that not all tumors have this kind of ability. Some lose it, like they become invisible. So radiations help further. There is also another factor, which is the PD-L1 expression, which induces the expression of the infiltrate. So again, there is balance.
Sapere oggi su questo modello.
What we can say, according to this model, is that immunotherapy is produced by radiation, but it's not enough to trigger a powerful immune response. Our experience can tell this, and it would have been better if RT worked in creating immune response alone, but immune response does happen nevertheless. There is a mutational burden towards a better response to ICI, and this is something positive, because if you have a tumor which is with a low mutation, it responds little to inhibitors. But on the other hand, if you have many mutations or subclonal mutations which change the pattern, creating the so-called private neoantigens, these clones cannot be found by a specific check, so this can create more difficulties. What radiotherapy can do is to increase the quantity and also the diversity of the T-cell repertoire, and this is important, and it's called antigenes enrichment. So radiotherapy alone has positive effects, but it's not enough. In order to move towards immunotherapy, you need to add the checkpoint inhibitors. The hypothesis is that ionizing radiation can stimulate anti-tumor immunity. And in this group by Santa Maria in New York, on a murine model, on which response was assessed by an abscopal effect, combining radiotherapy and a growing factor for dendritic cells, which is not checkpoint inhibitors. It's just a factor that stimulates dendritic cells. This is a demonstration, a combination of RT plus FLT3L. And this system is immunomediated because if you take away the possibility of the lymphocytes T and you inhibit the mice immune system, it is extremely clear how the passage from the effectiveness of this factor and response over time is mediated by the T cells. The other experiment was of a preclinical data and a single fraction versus fractionated radiotherapy. And studying the DT primers, which is an inhibitor of the actual priming, the start of the immunological chain, and this works well in other tumor forms, but mainly in the metastatic form, combined with other agents. This is a drug which was tested by the De Maria team in order to see if it was also possible to combine these agents to have an abscopal effect. This does happen, and it happens in a very interesting way, and mostly with 8 gray over 3 fractioning. In the meantime, this was not still not available in clinical practice, but the GM-GSF was used combined with the RT. This study combines this with radiotherapy in view of trying to repeat in the mankind what had happened with the dendritic cells, to have metastatic patients, and then assessing the abscopal effect on this study. There's not a very large patient population, so there were some biases, but what is evident, as you can see, on a total of patients which could be assessed, roughly 27 patients overall, you have a limited number of stable disease patients. So this is once again just abscopal effect. The survival was slightly improved in this study. This is not with checkpoint inhibitors. This was also interesting because radiotherapy combined with the checkpoint inhibitors. This was done by the University of Philadelphia. This is rather a complex study which took care of patients with metastatic melanoma with radiation and dual checkpoint inhibition activating non-redundant immune mechanism in cancer. And response on patients was reviewed, and the response pattern was not exceptional. It is not dramatically responsive. Neither is the survival, but those who responded went better than those who did not respond. It was important to understand why some patients respond to this combination and some don't in abscopal terms, combining or switching the model from the animal to mankind. So there were different combinations of radiotherapy alone and then combined with other therapies, and there was a growth delay, but partial. There's also a quarter of patients of 17%, which is again low. Why? What's the reason for this resistance? This combination doesn't work because there's a T-cell exhaustion. Several tumors are managed to resist. And they managed to resist basically because they express PD-L1. In the murine model, this ratio was in favor in terms of resistance for the tumors expressed with high levels of PD-L1. So the second step was to try the resistance to anti-CTLA-4 and radiation. On the blue curve, this is the murine model, which is higher with than the previous combination. This means that a dual inhibition of the priming receptors and those mediating their resistance and the cytotoxic activity is able to have better results. They re-stratified or relayered the results, and they were able to stratify these patients according to PD-L1, and the survival rates were considerably better compared to others who had a high PD-L1 expressions. And those respond less well to a combined therapy. The main findings were the anti-CTLA-4 promotes expansion of T cells, while radiation shapes the TCR repertoire of the expanded peripheral clones. But also, if you add PD-L1, in the CD8-Treg ratio, it further encourages this relation. This data was not confirmed by an Amston group with a concomitant targeting of program DEath1 and the CD137, in which the efficacy was demonstrated of 40 grays in a single fraction. Now, if you take a look at other stimulator, which is called CD137, showed some contraindications, because if you manage to inhibit one or two, or at least with dual or triple tumors, this opens the pathway for a better response. What happens if you do fractionated doses? And this is the anti-tumor immune response, and a more classic approach by a team in Manchester. You have the same effect, and fractionated radiation therapy can limit tumor cell adaptive resistance and can be combined radiotherapy with a checkpoint inhibitor. And this can be reversible if you and when you use an antibody which stops the PDL1 and gives a concurrent PDL1 blockade. And these are strategies rather similar. And you have to have PDL1 blockade on T lymphocytes. So this shows and demonstrates that if you have a conventional fractioning with 10 gray over 5 fraction, this is highly efficient. This is data on inhibition after 10 days after the therapy, and it is entirely due to a CD8 toxic alpha CD8 activity. This also happened in single fraction, yes. If on the animal model you do single fraction plus anti-PDL1, this promotes anti-tumor immunity. So there's a double resistance. It confirms the Philadelphia data on the action mechanism of the PDL1 and anti-PDL1 together with radiotherapy on the mice models. What do you do in clinical practice? In metastatic melanoma, and only in those cases, we could decide, given the ability of 3 molecules on the market. One is the antibodies for CTL4 and anti-PD1 and PDL1. This could be combined in clinical practice, and this can be done maximizing the response at local and distant sites. For example, in a patient when you need to maximize the results immediately, or you can think of doing it when a patient resists to a first line of inhibitors. The first line will be anti-PD-L1 because this has been approved. And then you can re-spur the response with the therapy. But these, in any case, are different possible combinations. Or you can do it enhancing a sequence similar to the Philadelphia experiment to increase the priming and make your antigens more visible to the immune system and develop resistance that adds to the PDL1 resistance. So you go in sequence. Nobody knows which of these 3 approaches is clinically more relevant. However, we have several phase 1 and 2 trials that combine these therapies in melanoma and lungs settings. Something has also been done in brain metastases with different combinations, very similar to the ones I've just mentioned. So we need to wait for the results of these studies to understand what happens in a clinical practice. What can we also do? We can also work on other inhibitors. Ideally, it is possible to target other molecules. We talked about the CDL37, we could do TGF-beta, which has released a lot after radiotherapy. It's immunosuppressive, has a strong immunosuppressive force. These are inhibitors of a tumor lung metastasis, and they tested in mice, and they are testing it in humans, a concomitant combination of RT, hyperfractioned, semi-ablative, ablational, with the intent of inducing abscopal effect. So this is once again a new option compared to inhibiting just the CTLA4. This data seems good in terms of also when we adding the PTL1. So this had to be demonstrated. And then combining the two effects can certainly contribute to the action, strengthen the action. So, in summary, what we know today is that RT certainly induces the ICD, the cell death, and is able to start the whole chain. RT-induced chemokines and stress-induced proteins contribute to the rejection of irradiated tumor, improving the microenvironment, particularly the interferon gamma. Unique T-cell clones emerge in tumors that are treated with RT and anti-CTLA4 given concomitantly. And this allows us to increase the possibility of action in terms of the immune system, even if we have a tumor immunity on other fronts. And this is extremely interesting. The changes in the TIL of the TCR repertoire after RT plus anti-CTLA4 certainly improve the local and distant response. We have experimental data on animal models, but still not on patients, and we need to wait for these before deeming this as a winning strategy. And we have significant results on a concomitant dual inhibition. CTL4 and PD-1, PD-L1 seems superior in highly immunogenic tumors, and it also functions well in other combinations. So there are different strategies in terms of dual combinations which could work, but we must bear in mind that these function in tumors who are already immunogenic. So the question is, what happens in other tumors, in the antigen presentation machinery? If we're losing the MHC molecules with antigen on the surface, it's very difficult to carry out a work on priming. What you need is to have go along another pathway, which may not be the right one, with the checkpoint inhibitors. So this works if the checkpoint inhibitors already function. In patients who are just purely resistant and do not respond nor in the first or second line to the inhibitors, it's difficult that this approach manages to turn on these response. But it's probably not the key solution for this. There are many questions pending, such as are any other mechanism involved in resistance? Probably yes, and still need to be discovered. And this is important for us, what sites should be treated first? Are there any difference in organs treated, brain metastasis? Should we give radiation to several lesions versus only one? Is there a difference in doses? Yes, we've seen this in the interaction with the epilim, but interaction with PD-L1, it's a more classic interaction. So again, on fractionation, we need to think about what exactly we want to aim at. And then a final concept, unlocking the abscopal effect. Is it feasible to unlock the potential of the combination, not just the abscopal effect? and it's the effect that it is pleasant to see for us and also for the medical oncologists. And it's interesting to see effects on different sites from the tumor. But again, in the melanoma setting, it involves a small number of patients, and never in terms of histology over 30%. So we must look beyond this combination. First of all, in locally advanced diseases, these are all tests that aim at this combination, because if you give radiation, you do have results, you do have a response if you use checkpoint inhibitors combined with RT versus using them alone. And this opens new scenarios in which abscopal effect is important, but we could use a standard fractionation in the lung or in the sarcomas. This is a new world. It is not just about metastases, but also in increasing local regional control. If you give radiation to lymph nodes and lymphatic system, you're possibly not helping the in situ vaccination system, because you're destroying all these cells who are responsible for the priming and cross-priming. So this needs to be thought in a different way. In metastatic patients, stereotaxy is certainly a positive option. In order to think beyond this, it's important to look at other models. Immunogenicity of tumors can be studied only with biopsies and trying to see the situation on site. There are no other imaging therapies or marker strategies. There could be biochemical or liquid biopsy, which can tell us when or how much the tumor is in equilibrium with the immune system. What we can do is go to the lymphocyte infiltration. If we do this with brain metastases, we can see that there are important results, and these are related to the patients with brain metastases have better results of those who do not have brain metastases. And this seems to go against some clinical ideas that we may have on the diseases. The idea of having a similar imaging helps us to make an attempt to use this combination, the right combination in the right patient. Polyimmunogenic patients require a new pathway. Those who are already immunogenic, we can use radiotherapy to strengthen the effects. In actual fact, and this is the end of my presentation, this is a proposed scheme of therapy. The crizotinib example, we have a patient who responded very well to TKI, and it works. At one point, you have resistance, and you have oligoprogressive disease or widespread progression. With SA-RT, we have imagined that the radiation or surgery to the sites of progression can continue to the medication. This is a good strategy, but only in a world in which you have a specific tumor for which patients progress because they change their genetic pattern on those specific lesions. So you have a stable disease, but it then progresses to the brain and all bone. And this has a sense to carry out ablation. In immunotherapy, it's slightly different because it's not so much ablating lesions and continuing as a drug that's already working. What we try to do is to use radiotherapy as inducers of the autoimmunity, anti-tumor immunity. Patients who have a weak endogenous response, and on these patients try to start increasing the availability and possibility of responding to the immune. So the concept is not ablating lesions who are progressing, but just to not use radical doses. The goal is different. We want to open the way to open the pathway to the immune strategy. The oligoprogressive model is not certainly valid for all patients, including those who do not respond to immune therapy. That's another experimental category. Bear in mind that the combined approach is already studied in many studies, so probably we will have patients who have done multiple combinations of immunotherapy, so we'll need to identify the therapy in a context which is slightly more complex. Thank you very much for your attention.
Grazie Andrea.
Thank you, Andrea. Dr. Ramella will take now the floor. Dr. Marchetti is late.
Buon pomeriggio.
Good afternoon. First of all, thank you, Piercarlo, for the possibility that you've given me to discuss about this topic. My role is to talk about the new combined therapies and the lung. And we've seen the biological premises for this association to work. So this can work and this can be successful. And of course, like all the tales, this starts also with the once upon a time. 3 years ago, when this case was reported by the New York University, we're talking about clinical data, a patient with lung metastatic disease and bone metastasis who underwent stereotaxis 6 × 5 in association with the therapy with ipilimumab. 6 months after the end of the treatment, there was a disappearance of the lesion, but also the distant lesions disappeared. This is an in vivo evidence of the abscopal effect. As a matter of fact, this demonstrates how the same patient is NED at 25 months. At the same time, in 2015, we had this trial, a proof of principle trial. Does this concept work? So radiotherapy was associated in that case with the granulocyte macrophage colony stimulating factor for blood cells. So progressing or stable disease from hormone therapy, undergoing 2 cycles of radiotherapy treatments and growth factors over the next 2 weeks. So the response was evaluated also in terms of abscopal effect. The radiotherapy was administered 3 grade × 10 on the lung lesion, but not only those. Let's be more specific. The abscopal response was evaluated this way as a 30% reduction in the lesion's diameter, the best abscopal effect. So many metastases, one is responding better. So that's the lesion we'll consider in terms of response. So we had a two-study trial. So only 1 patient out of 10 had an abscopal effect. There was the possibility to recruit the patients. Otherwise, the trial had to be ended. Only 4 patients demonstrated this kind of response. So 41 patients were recruited, and in 11 patients, so almost 1 out of 3 had this kind of response: 4 lungs, 2 breasts, and 3 other tumors. So the survival was twice as much, with a toxicity level what could be managed, especially fatigue and also hematological events. So this was interpreted as something that was very good, and also to start targeted studies. So the New York University launched studies on breast cancer, or melanoma, and other tumors, but also lung tumor. And so we reached the publication of this abstract at ASTRO 2015. So this is a work on refractory patients, so not responding to chemotherapy, with more than 2 measurable lesions, treated with pilimumab and radiation therapy 6 × 5, associated within 24 hours of starting radiation therapy. In this case, the response is defined differently. It's no longer the best abscopal response, but the sum of all the diameters of all metastatic lesions that had to have a 30% reduction. So not only the best response, but the total abscopal response on all metastases. So these are initial numbers which allow to have this kind of information. 27 patients, patient 7 treated and 8 in progression before PET. 12 were evaluable. In them, the best abscopal response was seen in high percentages. 3 were complete, 4 partial, and 5 stable. So we need to be critical. We have few data, and they need to help us. So these are the 3 complete responses as best abscopal response. The total abscopal response, so all the other metastases, had a major response or a complete response. So definitely important data. But if we look at the partial responses and the stable responses, these are associated with progression, with a progression in other sites. So we have the untreated site, the distant metastasis responding well, and then we have a partial response, which is associated with other lesions in other parts of the body, which are progressing. From a clinical perspective, this can give us many suggestions. Maybe the infiltrates and immunity is not arriving to all sites at the same way. But the clones that have caused these metastases probably are not the same, because maybe they're expressing different antigens. So we have a different scenario, which is changing progressively. So the abscopal response is very common in patients with lung cancer and metastases, and so they're continuing recruiting patients. During the ASTRO meeting some months ago, the Yale University brought some different data. They studied this kind of association from a different perspective, namely, so you have immunotherapy plus radiation therapy within 24 hours. In this case, we have patients under immunotherapy with a controlled disease facing oligoprogression. So we're saying the same things with different clinical data. Radiotherapy on the oligoprogression. 21 patients recruited. So the bone, the brain, the lung was treated with schedules, with different schedules. So 10 fractions, 30 gray in 10 fractions, rather than stereotaxis. As you can see, the mean time to systemic progression is 2.3 months. Not particularly promising. Only 6 patients, so 30% of patients, experience a time to systemic progression of above 3 months. Something that is also interesting to note is that there was no abscopal effect. Radiotherapy gave no response. So the local control was optimal, and only few patients could benefit from this kind of approach. So we compared the two methods, New York University concomitance and Yale University oligoprogression. Both deal with the metastatic lung disease. In the first case, we have a certain amount of patients with best abscopal response, and in the other case, no response. In the first case, a 6 Gray times 5, so no single fraction was used on all patients. In the second case, only in 26% of cases. Our question, what kind of fractioning stimulate the best the immunotherapy, should be discussed. Available data tell us that the single fraction is not any better than the other fractions. So you can see the tumor grows a little bit less. We also have data on the melanoma, and which tell us that the single fraction is not as good. And also we have in cancer immunotherapy and radiation therapy, 8 times 3 plus anti-CTLA-4 is better than the single fraction. And then on non-small cell lung cancer, we do not have enough data, but we can use the study from 2014. Of course, radiotherapy plus immunotherapy proves to be better. So 3 fraction radiotherapy, 12 times 3, which can be an indirect data. Let's talk about safety now. We have clinical data telling us that this association is feasible. That's my question. We have results on 84 patients treated with anti-CTLA-4 rather than other drugs. So they were treated sequentially or concomitantly in the other cases. The only difference is in the range of radiotherapy that was administered. No differences in terms of toxicity between the two different approaches. The only real difference is in the esophagitis, which can be expected. In terms of toxicity, the lung and the esophagus are known toxicity. Of course, fatigue, renal problems are more associated with the immunotherapy itself, but they can be well managed if we know the pharmacokinetics of the medications. So the conclusions were that we found that common toxicities of thoracic artery therapy should not be tackled differently. As Andrea was saying, there are many questions still unanswered. RT dose and fractionation, sequencing as well. Talking about the lung cancer, we have studies underway and universities that are studying different fractions, but also concomitant and sequential. But maybe the most interesting questions are what size should be irradiated, patient selection, what about patient selection, and maybe what's the best combination we should deal with. And in my field, we should mention TGF-beta. We know that with its activity, this can be scary, but it can also help. But in addition to this action, this also has different types of actions. One of them being immunosuppressive action. So it induces a state of tolerance for the tumor by the organism. If we try to skip this obstacle through molecules that are able to block the mechanism, maybe we can reactivate the response of T cells mediated by radiation therapy. This is the only study on this topic from the Stanford University, radiation therapy and Solimumab, which show the association of radiation therapy on the early stage of the lung, and these drugs can not only inhibit the effects of radiation therapy, the side effects, but it can also block and stop the tumor growth. We've already seen that the preclinical data are also very interesting. Therefore, I cannot provide definite conclusions because we're still talking about very small numbers of patients. But this very nice sentence by Formenti tells us that we need to rethink radiotherapy as a therapeutic modality that has systemic effects. And therefore, this association, which started with once upon a time and would have been a nice story, let's wish will end with they lived happily. Thank you for your attention.
Grazie Sara, io farei la discussione tutta.
Thank you, Sarah. Let's see if Dr. Alongi, Dr. Marchetti is at the airport. So they will answer to its questions.
Thank you, Piercarlo, for your introduction, for your invitation to this very important and event that has focused on some important issues which represent the future of our field of work. Today I will talk about the possible interaction between immunotherapy and stereotaxic radiotherapy in patients with melanomas. In particular, the purpose of the immune system is to restore normal tissue homeostasis, and when we have a tumor progression, most often there is we manage to overcome needs to overcome the immunity to progress and grow. Melanoma is actually the first cancer subtype where immune activating agents showed an advantage in survival of the patients also affected by other metastatic diseases. I will not go into the various molecules used. I'll just mention that there are two families, basically those who are called cancer vaccines and the antibodies. In terms of the vaccines, we have very interesting data, such as the GP100, which is demonstrated to be more advantageous, but most part of the attention of the oncology world in terms of, or with reference to melanoma and other areas, goes to selected molecules, in particular the anti-CTL4 and the anti-PD1. I will not go into detail, but just give you some general concepts. The ipilimumab acts in the scope of the anti-CTL4, and others such as ipilimumab or the nivolumab or pembrolizumab affecting the scope of action of the anti-PD1. The pharmacological approach has changed clinical practice, and this is evident with some studies such as this, published on the New England Journal. This is one of the most important studies in which basically it is demonstrated that if we take a look at the ratio between the two curves, dacarbazine versus placebo increases survival versus dacarbazine alone. This is yet another study in the absence of mutation. The message I'm trying to get across is that looking at the curve, nivolumab versus dacarbazine is much more advantageous in terms of survival. The pembrolizumab versus ipilimumab has proved to be more effective in advanced melanoma. But what we are really interested in is to see that the associations of these two drugs can further enhance this impact in melanoma for immunotherapeutic treatment. Obviously, each of these drugs can create the potential toxic effect. In terms of radiotherapy, it has already been said by the speakers before me, can represent an important tool to determine an amplification of the immune therapy, because this is able to promote a response of the immune system against the tumor, to simplify the concept as much as possible. This is obviously related to what has already been described, that is the abscopal effect. But if we take a look at the clinical evaluations and a clinical experience in trying to understand where radiotherapy and immune therapy can be effective in melanoma, it's interesting to take a look at this review, and Dr. Filippi has reviewed this in detail. And from this list of publication, it is evident that treatment with radiotherapy is able to determine on non-target sites abscopal effects. And this, in the melanoma disease, is mainly the area in which this has been seen more than others. This is another study in the Journal of Neurosurgeons that says that by adding ipilimumab in metastatic patients, the effect in terms of survival increases considerably. So the time when radiosurgery could benefit from this seems to lead also to an advantage in terms of survival. In this yet other study, compared to the absence of ipilimumab in the treatment of melanoma brain metastases, in the red squares you can see patients treated with SRS or WBRT. There's statistically advanced in favor of the therapy that adds the drug, and this is survival and not certainly local control. This study was already discussed by Dr. Ramella, and this is the experience from which this current trend also from behalf of radio-oncologists has started. And there are other experiences which have made an effort to describe the impact of radiotherapy combined with immune therapy in melanoma associated to ipilimumab. 52% of the patients associated with ipilimumab has given an abscopal effect, but the majority of these effects comes from sites which are distant from the target lesions. We move from the classic vertebral metastasis and moving towards whole brain radiotherapy, and we have results in the liver and the pelvic and so on and so forth. But what we are interested in today with the patients we see every day is not just an increase of the response on the radiation side, but on the distant side, but also an impact in the immunotherapy plus radiotherapy in survival. Another important issue and advantage compared to the single modalities is the timing. When should we add RT to immune therapy? This study doesn't highlight any difference in terms of interaction or timing between ipilimumab and RT. In this, instead, the three curves show specifically, namely the black line is the SRS during ipilimumab, and seems to be advantageous versus a different timing. That is a timing which is represented by a radiosurgery before ipilimumab or radiosurgery after ipilimumab. So, as speakers have said, like Dr. Filippi before me, it's as if radiotherapy done before can generate and a sort of immunogenic source opening the way to the immune therapy. Another question we pose, given that most of our patients are under immunotherapy, should this be associated to the induced time or maintenance time? The patients who do maintenance seem to be better results compared to induced radiotherapy. So radiotherapy during maintenance seems to find and to give better results in terms of survival. In terms of dose, we have spoken a lot about the dose, and we have understood we still have no relevant data. In melanoma, we have this preclinical study which highlights how increasing the date could have an impact on the immune therapy for intracranial interbrain lesions. But this other experience, which I mentioned before, shows how the sole correlation existent is for doses below 3 grays. So it seems that the better results have for patients which we use radiation which can be considered as a palliative treatment. However, this other study shows that when we give whole brain, we have a detrimental effect in the first 6 months, versus the SRS seems to have an advance impact with the dose increasing exponentially. So these are single experiences, but this to tell you that probably the issue of the dose still needs to be studied. Toxicity, we need to assess this, as the Americans said, negligible effect, and this is within very limited percentages than we would expect by the combination of SRS with ipilimumab. And this is limited to a restricted number of patients. Again, this study highlights how associating radiotherapy probably does not increment in an intracranial setting the toxicity, which is already highly contained. So should we want to reach some conclusion in terms of toxicity, we could say that basically no unexpected toxicity from radiation have been observed for this in the scope of melanoma, are rather negligible and to be deemed acceptable. Most probably, this is a chart in which I list all the studies on the interaction between radiotherapy and immune therapy. And in melanoma, they are different, which probably will be able in the future help answer all questions regarding the most appropriate dose, the most appropriate fractionation, the most appropriate timing, and most probably also confirming the toxicity in the association. Combination is rather limited. So, in conclusion, as has been said before, preclinical models and clinical data shows that RT to one or few melanoma metastases might trigger or enhance abscopal effects, and prospective trials are ongoing to define which test is going to be the best. Thanks.
Grazie. Filippo, rimani pure.
Thank you, Filippo. You can stay here. I wanted to thank Filippo, Sara, Andrea. Very hard topic, very difficult field, challenging, and you did an excellent job. both on the timing. So the first introduction by Alessio Morganti draw some conclusions, and probably some of the things that we give for granted are not so granted. But the use of new drugs, as we were saying, medical oncologists are very happy about stereotaxy, and this is our conference on the stereotaxy. So in 1 week, you get a patient back with no side effects, and they can continue their therapies or experimentations. But we don't have the classical observational period. Sometimes there are associations that we do not know the side effects of such associations. So this is the real danger. So many things about the doses, what kind of volumes or fractions, but very often there are combinations with drugs we know nothing. Any questions? Just one remark. This is very important. I remember when I was a resident, we were running after oncologists, and now we're always on the phone with them. And then we give the patient back to the oncologist, very often with no side effects, because there are no strong effects. But we need to understand better such interactions, which are new. I had to study much on this because there is a lot of confusion. Can we do this drug with radiotherapy? Maybe melanoma is probably a niche, but these drugs are becoming a clinical practice, common practice. So we need to fill some gaps and give answers to the oncologists for the sake of the patients.
Oh, scusa. The speaker is off mic. We all have our oncologists of reference, and mine said, why don't we do a work team, a group, because I want to know if you have a patient, if you give radiation or not, because either you study the association. When this person told me, I asked my colleagues, medical oncologists, if they had any issues, any problems in giving radiation. They told me that they always do. And I answered, because they don't do follow-up. Because if they're unable to follow the patients, and these patients are metastatic, and this is a commitment also in terms of follow-up, and then it's difficult to understand if for all radiotherapy this can be associated. Intestinal fistulas and reported in literature can be something that can trigger an alarm. So we have some medications in the lung tumors, which ipilimumab or other medications are rather interesting. They don't point towards very high toxicity. But as we were saying before with Professor Gentile, the brafamib or the rolafulib, there are other agents which have created issues. So it's a duty that we have to open up to drugs of which we are sure that create no toxicity.
Concordo assolutamente.
I agree with what she said. We know little about this, as sometimes we underestimate. This has happened to all of us, and we find out after the treatment that they're taking other drugs. So we underestimate this problem. So we need a different approach, more comprehensive approach, and also a collaboration with the oncologist.
Fare un commento se non vedo altre, proprio perché manca l'oncologo medico, no? Adesso nel tumore.
In the tumor of the lung, the data of immune therapy in the second line of the metastatic patients are current ones. In the squamous, we can also, everybody can do it. In non-squamous, some can do. But pembrolizumab in the second line, we find metastatic patients who just do vertebral metastases or other lesions. This can be very typical. Right now, we have currently had data of pembrolizumab in first line for lung tumor and has given better results compared to chemo with platinum. So this is, so to speak, devastating answer, and it's the first time that this happens. Therefore, we need to take into account that these patients can benefit based on these new discoveries.
Sì, su questo se posso aggiungere.
If I can add something, we have safety data. They're not coming from a phase 1 study, but they come from observational studies. But we're lucky because these observations are positive on the immunotherapy. So other than increasing the efficacy, but what you're saying, that your study is a historical study because it's speaking about those combinations with no specific effects. So it's very impressive, and for us it's much better because a patient on platinum has more possibilities. So it paves the way to many other possibilities. I don't know, maybe we don't know what it does on the lungs, but on metastatic tumors, no enough safety data. We're also lacking data on the combination of ipi-nivo and radiotherapy, but they will come soon. So the combination is probably more toxic than the anti-PD-1 alone, but no particular problems with radio on patients that tolerate them. So they can start with no problems because they respond anyhow.
The oncologists also say that don't see toxicity, not only financial toxicity. So it arrives at 100,000 euros per treatment. So clinical toxicity has been overcome by financial toxicity.
So a little problems with transportation today in Rome. Well, thank you. Thank you for having attended this conference and safe travel back home.